traveling and sightseeing and this thing, that what we see there in the conference and here lecture is maybe 50% or so. Maybe PGs sit from morning to evening, but if you see that inside, many will be seeing their even mobile WhatsApp and all. See, I have seen even Ganga Anastasya update. I took a photo also from the back seat. It is very highly rated and all that, but people sitting there just looking that is not that. When we go there spending money, time and all, we should sit there. I was not able to attend the CMEs mainly because with so many business aspects during this conference. Because okay, somebody will call Giri, what this they are all student are hearing the lecture, we will have sit outside and talk, and we have some business meeting. But at least people are coming for CME also. If you see in the national conference, the hall sometimes maybe 2 or 3 people, the person taking the photo, the chairpersons and the faculty, others are not there. But in this, whoever is wants, it takes at least some people and come and hear and join and without spending your time or money and our knowledge, definitely. At least I have attended many CMEs during this webinars. Otherwise, it was only during when I was a chairperson, I was sitting there. That I did not attend. Maybe I was outside only in this. Maybe last 10 or 15 years with the ISA activities. Entering the CME hall was only for inauguration when I was chairing. Otherwise, it was only outside. So many people must have increased, and we have taken the advantage of this COVID time. Maybe it will continue for some time, and people will get interested. But what we miss is interaction with the other persons and all. We miss a lot. Maybe see this after 1.5 years. Yesterday I attended a physical meeting for the first time in Mangalore for one meeting. Otherwise, after March, did not. Now we will have that, and today we have good faculties because very popular. Because Jamishidra I have heard only and in the CMEs and other things, but seeing for the first time from Canada, because every time it was being heard. Shivkumar Singh we are seeing a lot of times in the Facebook and his blogs and then scientific discussions or many discussions. Maybe for some time I was a little behind in now Facebook. Now again to start and see that. And our own faculty is always there, Ashok Garden, with the programs whenever it is there. With that, you have selected good speakers, and hope all will join and enjoy the CME and get benefit out of it. And I wish all the best for Dinesh Singh for his tenure as president. And I will come there during my presidentship and your presidentship to Bihar, and we will have personal meeting in Bihar sometime and have that. And maybe in your place, Dhanbad or wherever it is. One day I will come and we will have a meeting. See you in, please come to Ahmedabad for the conference and installation. Manoj, even if you are not there during my term, I will definitely come there and be there. We will have a meeting there. Okay?
Thank you.
And I'm happy to be participating in this, and over to you for the scientific proceedings.
Thank you very much, sir, for your kind words. Thank you very much. Bihar and Jharkhand is always getting support from the national, especially Dr. Venkat, Dr. Murlidhar, Dr. Naveen, and everyone. Thank you very much, sir. Now I will invite our GC member, Dr. Manoj Kumar, to say a few words. Then we will immediately move to the program. Dr. Manoj Kumar.
It is my great privilege to welcome all of you, especially our chief guest, Dr. Venkat Giri, sir. Our coordinator, Dr. Shiv Kumar Singh sir, our next coordinator, Dr. Ashok Jadon sir, and a speaker from the Katihar and from Ranchi and Muzaffarpur. All speaker is very good from ISA Bihar and Jharkhand chapter. And I warm welcome to all the delegates and speaker. And very thankful. I am very thankful to Dr. Sarad and Dr. Our treasurer Neelam madam. So please go ahead, Dr. Sarad.
Thank you, Dr. Manoj. Thank you very much. A very special friend from Canada who is very close to us, Bihar and Jharkhand, Dr. Jamishidhar sir. Because I know you are busy, just wanted to take your opinion about, because you love Bihar and Jharkhand so much that you always in touch with us. So please go ahead, then I will start the session with calling the moderators.
So thank you, Sharad. I actually follow your CMEs and blogs, whatever it is, but since the pandemic started, the situation has absolutely changed in Canada. Traveling is extremely hard, and the flights have been cancelled, and so we are confined to our couches, whatever you say. But I have special and a little bit of conflict of interest to be towards Ranchi and Bihar, like because I worked in Ranchi for 2.5 years, and I traveled extensively across Ranchi, Bihar, Patna, everywhere. So we know that, and me and Sharad worked for some time also in Ranchi. So thank you very much, and I'll be always be supportive of you people. Hopefully by next time I visit you guys. Thank you very much. Thanks for inviting me. No problem.
Thank you, Dr. Jami. Thank you very much. Now we are going to start the session. Before that, I would like to introduce our moderator. We have two moderators, and today's theme is ultrasonography, USG, and anesthesia. So first moderator of the day is Dr. Shiv Kumar sir. Dr. Shiv Kumar is the consultant anesthesia at the Royal Liverpool Hospital, UK. He is the chairman, theatres and anesthesia, facility audit and improvement lead. He is also the regional anesthesia lead. He is the visiting faculty at BIDMC, that is Harvard Medical School Hospital, Boston, USA. He is the editor, Anesthesia, Pain and Intensive Care, Epicare Journal, and Journal of Anesthesia and Critical Care Case Report.
Hello.
He is the reviewer of the Central Commissioning Facility, CCF, Research Management System.
Oh, no way.
He is also the reviewer of the Regional Anesthesia and Pain Medicine. He is executive member of British Association of Indian Anesthetists. He is the convener and patron of the Global Anesthesia Society, which has more than 30,000 members. He has 30 years of anesthesia experience, 6 years in India and 24 years in United Kingdom. He has 46 publications in his name, 1 chapter in the book, and 1 chapter in the teaching manual. He has reviewed 1 book, review article 2, editorials 4, original research and case report 37 in his pocket. So now I invite Dr. Shiv Kumar Singh sir, then I will call Dr. Ashok Jadal sir. Dr. Shiv Kumar sir, please unmute yourself. And before that, I request everyone to please mute your mic. Please mute your mic, everyone. I request everyone to please mute your mic. If you want to say anything, please raise your hand. We will call you definitely. Dr. Shiv Kumar sir.
Thank you very much, Sharad, for the kind introduction, and a very good evening from India, especially to Dr. Venkatagiri, the president-elect, Dr. D.K. Singh, who is the president for the Bihar and Jharkhand Society of Anesthesiologists, and to my co-moderator, Dr. Ashok Jadal. And obviously, I think warm welcome to all the speakers. I'm actually looking forward to listening to Dr. Gautam, Dr. Nasrul, Dr. Tushar, and Dr. V. Mohan. And obviously, thank you to all the organizing committee, the coordinators, Dr. Nishant, the scientific chairman, Dr. Dev, Manoj, Dr. Manoj Kumar, and Dr. Sharad, of course, who's personally invited me, and Dr. Neelam, who is the treasurer. I always tag her because she is one of my Facebook friends, so I always tag her to the post. So thank you very much for inviting me.
Thank you, Dr.
Something gone wrong with the sound, Dr. Sharad? I think you are muted, Dr. Sharad.
So please unmute yourself, sir.
Sorry. That's my mistake. And the next moderator of the day is Dr. Ashok Jadal sir. Although Ashok Jadal sir doesn't need any introduction, he is very famous in the pain physician, as a pain physician, and always available for any query. If you have, please ask Dr. Jadal. He is always there. So, but it is customary to introduce our moderator. So I would like to say something about him. Sir, Ashok Jadal sir has 31 years of clinical experience in anesthesia, an interventional pain physician, 14 years of experience in the interventional pain procedures. At present, he is the Chief Medical Superintendent and in charge Pain Relief Service, Tata Motors Hospital, Jamshedpur. He has more than 100 publications in his name. national and international. He has eight and textbook of essential orthopedics, basics of pain management 2016. He has many awards in his pocket. He was nominated award for the Susan Raj Pain Physician Award 2011, 12, 13, 14. Ranbaxy Oration Award 2013. Academic Excellence Award by EET-CRS in 2013 and 2015. Alankar Award 2015 and 16 by the Tata Motors for Pain Practice, Academic Publication and Social Work. Nomination Award in Low Cost Treatment in Pain Management, ICRA Pain 2016, Kolkata. Lifetime Achievement Award by VD Good Technology, May 2021, Goa. He is a very renowned DNB teacher, external examiner, thesis and exam paper assessor of DNB board. And he is the reviewer in the journal, prestigious journal like IGA, SJA, JOACP, and is the life member of ISA, ISSP, and IMA. So now I invite Dr. Ashok Jadal, sir.
Thank you, Dr. Sharad. I think this was little inappropriate to take lot of time for introduction of moderator, but I am honored. And the dignitaries here, Dr. Venkat, Dr. Shiv, Dr. Dinesh, I know them for longer than my own career. I know them quite a long time. They are the real pioneers. I know Dr. Shiv's credentials. You need already mentioned, but he's more than what we have said. And so without wasting any time, I think we have to continue and listen the speakers who have prepared, I think, and will enrich our knowledge, existing knowledge. Thank you so much for keeping me aside or near the Dr. Shiv for this coordinator work. Thank you so much, Dr.
Dr. Ashok, it's a pleasure to be with you, coordinator with you.
Thank you.
Thank you very much, Dr. Jadal. Thank you very much. Now the program we are going to start, and I request our moderators, Dr. Shiv Kumar and Dr. Jadal, please start the session because now this is your baby. Please start and continue the CME. Call the speaker.
And Dr. Shiv, you take the honors and please start.
I don't know any of them, Dr. Ashok, so I think you'd be the best person to start off with. I think you know them well. I think that's why. I think it's better that you start. You know them well rather than me. So I think it's most appropriate. And you've been the senior. So I would
Dr. Sharad,
put the ball back into your court. The ball is in your court now.
I have another plan. Dr. Shiv.
Okay.
Can you start actually by calling the speaker, and then me and Dr. Shiv, I think, will give some briefs about their presentation and what good they have spoke about. I think, Dr. Shiv, that will be more appropriate.
Yeah. Okay. So you can introduce them, but can I please invite Professor Gautam Piplai? He will be talking about basics of ultrasound, and Dr. Ashok will introduce the speaker. Thank you.
Good evening, sir. I am Dr. Gautam Piplai of MGM Medical College, Kishanganj, expressing my heartiest thanks of Bihar and Jharkhand Society of Anesthesiology for.
I think Professor Gautam is actually, I think, having some problem with connection. I think there's.
No.
Okay. Yeah.
Start, sir. Okay. Can I start?
Yes, please. And
good evening, sir. I am Dr. Gautam Piplai of MGM Medical College, Kishanganj, expressing my heartiest thanks to the Katihar branch of Bihar and Jharkhand Society of Anesthesiology for giving me opportunity to deliver a talk in the 9th CME on of ultrasonography. Please allow me to share my screen. Sir.
Please share your slide, sir. Please share your slide.
Has he been given the permission to actually share screen? Because until he's been given permission to share screen.
Yes, sir. He has given this.
Okay.
Please do, sir. Please share your slide, sir.
So, sir, host disable screen sharing. Host disable participants screen
That's what
sharing.
I thought. Yeah, there is no permission to share screen. It should be actually given from the.
Please try again, sir. Please try again.
Please try again, sir. You are the co-host. Please do that, sir.
Yeah, it's coming now.
Yes, sir.
Got it, sir. So good evening again. I am expressing my heartiest thanks to the Katihar branch for giving me opportunity.
Enlarge your screen, sir. Sir, and enlarge your screen.
So can you hear me?
Yes, we can hear you. They want you to actually go on to the slideshow. Yes, yeah, it's fine now. It's very good.
I'm going to my slideshow. This is the basics of ultrasound is a form of mechanical sound energy that travels through a conducting medium as a longitudinal wave, producing alternate compression and rarefaction. It is sinusoidal waveform with characteristic pattern. We can see the wave and the amplitude. There is a rarefaction. And so the wavelength can be visible, the frequency and the speed. The frequency of the sound, if it is 1 cycle per second, that is called 1 hertz. Many thousands of cycles per second is called kilohertz. Millions of cycles per second, megahertz. Billions of cycles per second, gigahertz. And trillions of cycles per second is terahertz. Audible sound is 20 to 20,000 hertz. The ultrasonic waves, which is not audible, is more than 20,000 hertz. But medical EE, we use 2.5 to 15 megahertz. The piezoelectric crystals are the heart of ultrasonic waves. The crystals are made of materials like quartz, topaz. Out of that, lead, zirconate, titanate is the best piezoelectric crystal. Some naturally occurring piezoelectric materials are bone, proteins, DNA, and sugar. Piezoelectricity is the electric charge that accumulates in the material mechanical stress or vibration. Crystal can convert mechanical energy to electrical energy for sensing or energy harvesting. Also convert an electrical signal into motion for actuating. The states of the piezoelectric crystals, that is unstressed, stretch when it is stretched, and the compressed. So we are going to the other uses of piezoelectric crystals in our daily life. In seismograph, ignition of vehicle engine, watch beepers, smoke detection alarms. So on the contrary, silicon is piezo-resistive. The benefits of ultrasound: generally painless, does not require needles, injections, or incisions, no exposure to ionizing radiations, therefore safer diagnostic technique is compared to X-rays and CT scans. Can show images of soft tissue that don't show up well in X-ray images. All organs are visible except lung tumors because the air impedes the passage of the ultrasonic waves. It's a real-time imaging technique. The knobology. Knobology is a terminology that describes the manipulation of ultrasound knobs and system controls in order to obtain the best image possible from diagnostic ultrasound. The probes of transducer, according to the different shapes, they deliver the different frequency waves and their use are different. The transducer probe is the main part of the ultrasound machine. The transducer probe makes the sound waves and receives the echoes. It is, so to speak, the mouth and ears of the ultrasonic machine. The transducer probe generates and receives the sound waves using the principle called piezoelectric effect. In the probe, there are piezoelectric crystals. When an electric current is applied, it changes or vibrations of the crystals produce sound waves that travel outward. Conversely, when sound or pressure waves hit the crystals, they emit electric currents. Therefore, the same crystals can be used to send and receive sound waves. How many crystals are in the ultrasound transducer? The linear probes will vary in width according to the number of crystals elements, ranging from approximately 64 to 512 crystals. To produce an ultrasound image, linear array type probes employ sequential firing of groups of elements rather than sweeping the crystals like sector technology. So this is the transducer parts. These are parts of the transducer. Is a piezoelectric material. The crystal ranging from 64 to 512 crystals in number. They are in place. In one place, the sensor electrodes, insulated layer, backing block, acoustic insulator, insulating cover, and transducer housing. The selection of the probe. Transducer probes come in many shapes and sizes. The shape of the probe determines its field of view, and the frequency of emitted sound waves determines how deep the sound waves penetrate and the resolution of the image. So when the sound waves are high, they cannot penetrate much, but the resolution is high. When there is a deeply situated organ, the frequency should be slow and the resolution will be good. But lower frequency gives rise to lower resolution, always. In addition to probes that can be moved across the surface of the body, some probes are designed to be inserted through various openings of the body, like vagina, rectum, esophagus, so that they can get closer to the organ being examined, like uterus, prostate gland, stomach. Getting closer to the organ allow for more detailed views. Selection of transducer. The superficial vessels and organs who are situated within 1 to 3 centimeters from the skin, we use the high frequency probe that gives 7.5 to 15 megahertz. The deeper structures in abdomen or pelvis who are situated more than 12 centimeters away from the skin, we use lower frequency probes that is 2.25 to 3.5 megahertz. There are the different types of probes, the linear probes, curvilinear probes, and phased array that delivers echo. It is lower frequency echo ranging from 1 to 5 megahertz. It can go high depth. A small surface area like ribs can be visualized using this type of probe. Good for movement. Curvilinear probe, where there is a big size and many organs are situated, like in abdomen, and the echo can go to high depth. We use 2 to 5 megahertz. The probe can be used for large surface area. We can see the pleura also and the collection of fluid in the pleural cavity. The linear probes, they are used for vascular access. Superficial structures like nerves, thyroid, breast, testes, and veins, they can be visible. They are situated from skin and within the distance of 3 centimeters. The high frequency probes, they are releasing more than 7.5 megahertz, and depth is low and large surface area can be used. The transducer use different movement of the transducer, and by manipulating depth and button, we can see, we want to see the actual picture of the organ. For that, we use the focal point and focal zone. When the organ is in focal zone, the picture is very good quality. The pulse reception frequency. When there is release of the pulse, one pulse releases 2 to 4 echoes, 4 cycles, and that after release, the probe cannot release again to stop idle to receive the echo from the targeted object. If it gets, it is transferred to the electrical energy to form an image. The components of the ultrasound. The 5 basic components are required for generation, display, and storage of an ultrasound image. The pulsar, applies high amplitude voltage to energize the crystals. The transducers converts electrical energy to mechanical energy and vice versa. Receiver detects and amplifies the weak signals. Display displays ultrasonic signal in various modes. Memory stores video display. Modes available are amplitude mode, the A mode, brightness mode, the B mode, used in USG guided regional block, motion mode, M mode, used for heart and cardiovascular surgery. Often we use it for echocardiography, color Doppler mode, and power Doppler mode. Applied skills and basic approach to ultrasound imaging. We can see the many companies are producing many ultrasonography machines, but the basic technology is same. So we can see it from the top, the different buttons and different modes, the screen and it is the gel. The steps to perform an ultrasonic examination. Switch on the machine. As per the organ for examination, select the probe, select the type of examination, apply jelly on the probe, appropriate amount, so that it should not be very much or very less. Put probe on the relevant body part. Probe physical manipulation and movements to get the image. Mode selection and change during examination. Image adjustment if required, gain and depth, that both can be manipulated. After getting the ideal image, the screen is reached for the measurement and use the caliper tool. Rotation done, report can be printed, report also saved, transferred to the pen drive or USB. Wipe up the jelly and send the patient out of the room. So these two things I'm showing the on-off button and the selection of the probe button. So this is the screen. We can put the button on for the abdominal examination, or we can get any examination, gynecological examination, you can put on the button on. So on-off button is on, the machine is ready for use. So little short video to how we are using in our hospital the ultrasonography machine and the examination. After application of the gel and selection of the probe, we are holding the probe in the region to get the image. We can show the manipulation of the probe, that is sagittal view and the transverse view. We can get from the manipulation of the probe. We can manipulate the probe in different ways. There is sliding movement, there is tilting movement, rotating movement, and rocking movement. So this is a small video to show the sliding movement. This is a compression. And the vein, artery, and nerves, we can see the veins are compressible. Artery cannot be compressible. This is pulsatile. This is a rocking movement. You can see. This is a rocking movement. This is a rotational movement. And see, this is the tilting movement. All the movements to get the picture quality best. So the little bit small video is the use of pointer. We are using this pointer in an appropriate direction. It should be always in the right side or towards the head of the patient. If we do not examine the heart, other examination, the pointer should be right side of the patient or towards the head. This is the pointer. And these displays the different modes. The 2D is the normal mode, color Doppler, power Doppler mode, motion mode we can use for echocardiography and pulse wave. This is pulse wave Doppler. So you can see the flow through the artery, and veins cannot show that much of flow. Is static. This flow is low, and venous flow we can identify in comparison to the arterial flow. This is wavy. This is the color Doppler we can use to see the vascular supply and turbulence. The red part is visible when the blood comes towards the probe, and the blue part is away from the probe. So when there is a suspicious about the small vascular supply, we can use the power Doppler. So the power Doppler can detect the very small arterial supply or vascular supply or pulsatile arteries or collaterals if there are. The low flow states, there is a non-directional color. Most modern machines automatically adjust images for best settings. However, we can still choose to perform image adjustment. So gains are measured. Say overgain shows bad picture, undergain shows black pictures, and appropriate gain shows the correct picture. When there is a depth, it's a depth. When there is a shallower depth, when is from the skin, it is with the 3 centimeter, we push the button the shallower, and when it is more than that, you put the deeper depth. This is the measurement of the organ, the freezing, calipers, and measurements. Say A and B, the pointers. See, we can calculate using trackball. So now the documentation, patient's name, ID, they are entered, the text is labeled, everything is saved, the video is clipped, video is saved, clip, and we can transfer the everything to a pen drive or USB port. Little bit small video. So we are transferring our every documents before giving to the patient. Now see our demonstration done at MGM Medical College and LSK Hospital, Kishanganj. See, one patient has come with a pain abdomen. So the sonographist is quickly selecting the probe and the exam, this abdominal exam. The patient see the kidney is visible. So kidney is visible. So calyces are visible. Now we are showing the carotid artery at its bifurcation. The two branches, you see, they are pulsating. You see. So meanwhile, we can change the probe also. So if the probe is not, if the person is not, the doctor is not satisfied, so he can change the probe. We can take the another probe, which is this. Meanwhile, in the exam, within the exam, the person may change the probe also to show, to get a better result. So here we can see the brachial plexus. Yes, it's the brachial plexus. And the subclavian vein, which can be compressible if pressure is applied. Now the take-home message. Ultrasound is the stethoscope of the future. Imaging cannot substitute clinical judgment. Practice, practice, practice for more perfection. The acknowledgement to we are our colleagues who helped me to make this presentation fruitful. Dr. Anil Chandra Jain, Senior Resident of this medical college, Dr. Manish Kabrani, Senior PGT, and Dr. Sagar Rai, also Senior PGT of this institute. Thank you.
Thank you, Dr. Gautam. It was a very basic of ultrasound, because many of us really experienced in the ultrasound, but many of us really do not have the access to ultrasound, and if they are also eager to learn and proceed further. So this lecture would have been really a very helping and knowledge sharing to them to understand about the basics of the ultrasound. May I now call upon the next speaker? I think we will keep questions in the last. Dr. Tushar.
Can Professor
Yes, sir.
Gautam stop sharing his screen, please? Is Professor Gautam need to stop sharing his screen?
Yeah.
Dr. Ashok, sir.
Yes, Dr. Manoj.
Question answer session after the
In the last.
speaker. No, sir. Please, sir. After completion of speaker.
Okay.
One speaker.
Okay.
I request you.
Okay. It's fine. So, Dr. Gautam. Yeah, it is to the all participants. If any question to the Gautam, sir, please write down in the chat box, so I can read and communicate to him.
Sir, one question from my side.
Yeah, Dr. Manoj.
Very nicely presented, Dr. Gautam. My question is, what are the limitations for the ultrasound in anesthesia procedure, and what type of other transducer used in the transesophageal, transvaginal, or transrectal? So any sedation or any type of anesthesia technique used for these transducer? Introduction of the transducer.
May I answer the question?
What are the limitations for ultrasound preparation technique in anesthesia procedure? And
okay, Dr. Manoj, I just convey the question. There are the three questions. One question has three parts. Number one, what are the limitations of the ultrasound in clinical practice? This is question number one. Number two, there are other specific type of probes also, like transvaginal, transesophageal. What is their role in brief?
transesophageal
and transvaginal. And Dr. Manoj, any third question? I think these two portions you have.
No. These introduction of these transvaginal, transrectal, can we use sedation or other anesthesia technique for pain?
Yeah, for any ultrasound procedures, whether the sedation to be used, and if it is used, what is the appropriate amount and the drug you want to use for the sedation?
Yes.
Yeah, Dr. Gautam, you have to unmute yourself first.
Sir, so I have shown you the different types of probes used for different purpose: esophageal, transvaginal, rectal probe. And during that introduction of the probe, we need some little bit of sedation. We used to sedate the patients. Otherwise, in other probes, that is seeing the brachial pressures or doing these things, that is echocardiography. So we do not need much sedation, but transesophageal ecography, sometimes the patient needs a little bit of sedation or application of the local anesthetic during insertion of the TE. Or other, we are using very little sedation, and just the patient is a little bit sedated and can tolerate the insertion of the probe, and patient is, well, that's fine, no problem. Only lung, in case of lung, no, I cannot. So lung lung tumor cannot be visualized by using the ultrasonographic probe, because this air impedes the transmission of the ultrasonic waves, and we can see the pleural effusion and mediastinal some sort of any other pathology, except the major pathology, that's a tumor. We cannot predict that image quality is very good in case of lung. We can use curvilinear probe for lung.
Yes, very nice, Dr. Gautam. Dr. Manoj, just to add on, obesity, any structures behind the bone and the air, there are the three things which actually interfere in the good observation or good imaging of the ultrasound. So I think these are the three limitations in the clinical practice. Very obese patients, we are unable to see deeper structures. If air is there, it will definitely interfere in the interpretation of the underlying structure. And the bone, if you want to see something below the bone, it is not possible, because all the ultrasounds will be reflected back. I think we should proceed with the next speaker. Or any other question is there? Any other, somebody else?
Thank you, Ashok sir, and our speaker for nicely answered my question.
Dr. Shiv, any expert comment to add on what I said for the Dr. Manoj?
I think you have to first of all divide what are you using ultrasound for. Is it diagnostic or it is therapeutic? So for diagnostic, most of the diagnostic, you did not need any kind of sedation. Right, diagnostic, like if you're doing echocardiogram, transthoracic, you don't need to. Patient might feel a bit of pressure, okay? And transesophageal, yes, can be done with just you can apply jelly or spray the oropharynx. Okay, sedation. Some patients, if they are very anxious, you can give them mild sedation with either midazolam, bit of fentanyl, or even a little bit of propofol, depending on where you're doing it and how safely you can actually do that if you have got the monitoring. Now, even for therapeutic, I think it is overdone. Even for blocks, I have put catheters without actually doing any sedation in patients, nerve catheters. Patient tolerated well if you give proper local anesthesia. So it's not always necessary that you have to actually sedate the patient. And when you're sedating a patient, you need to actually have minimum standard of monitoring. You need to keep the monitoring as well, and need to have somebody skilled person along with you. So don't take it too easily. Okay, so it just divided diagnostic and therapeutic. Diagnostic, you don't need much. It's done by cardiologists or done by gynae people. You're talking about transvaginal, and no, they don't require. No obstetrician don't call you for actually sedation for patients who are actually having transvaginal examination using ultrasound. And same thing abdominal. So that's not. And again, we are not actually involved. But for example, if you're actually going for, say, ovum retrieval, where that is actually now a kind of therapeutic, they are going to put needle through the probe, you will need to give sedation because it's going to be a painful procedure. And the other thing about the use of ultrasound in basics of ultrasound, there are something which we always teach, obviously, after you have got the ultrasound and you have done all the setting. So that's all done when you do something called a scout scan. It's in the scout scan when you actually adjust the patient's the depth of the gain, right? The presets, nerve preset, or you're doing the musculoskeletal preset. You actually do that in the scouting scan. And There are certain maneuvers which help to visualize the structures. Okay, that is then is known as parts. Part is for pressure. You do apply pressure. By that, you're approximating the skin or the probe towards the the structure you're going to visualize. And you can actually use high frequency probe if the depth is much less. You can get better images. There are various ways. Even in the morbidly obese patient, you can actually get a very good image if you actually apply. That is a totally different lecture. Actually, you can actually find that on my YouTube channel. I've actually given a lecture on that. You can do that. And parts is basically piece for pressure, and then you align the probe to the structure you're going to visualize by doing rotation, tilt, or rocking movement. If you're using a curvilinear probe, you tend to use a lot of rocking movement to actually visualize that. And then tilting. Now, certain structure have something called anisotropy. At certain angle, they will become visible, okay, and then they'll disappear. You change the angle, they disappear. So that is called anisotropy. So tilt is actually, again, very, very important. Then is the sliding. The sliding part is not actually part of the visualization. So tilting and sliding is when you actually have hand-eye coordination. When you do a needle and probe, you have a credit card thin beam and you have very thin needle. They need to be aligned. So you need to align by either actually, tilting, rotating, sliding. Those are all part of sliding. So it's what we teach in the courses where you actually look at, you are only visualizing. You're actually teaching how to visualize structures. We do not actually teach you how to actually optimize the needle visualization. We have phantoms. Phantoms are easy. They are single homogeneous structures, but when you are going through tissues, different tissues, you don't see the same image. It's not the same image. So that's where practice actually comes. I think I've answered too much, I think.
Thank you, Dr. Shiv.
Thank you, sir. Thank you.
To this add-on. I think, Dr. Sharath, we can move on to the next speaker.
Yes, sir. Yes, sir. Please go ahead, sir. Please. Yes.
So our next speaker is Dr. Tushar. He is assistant professor in RIMS Ranchi. He will be talking about the central and the peripheral venous cannulation by ultrasound guidance. Dr. Tushar, please.
Thank you, sir. Am I audible? Is it every?
Yes, you are audible. Yes.
Okay, fine. Thank you. Thank you, sir. And thank you very much for inviting me to speak on this platform. So ultrasound is not very old or not very new, I think. We have been using ultrasound since very long. And but popularity, it has gained its popularity for recent past years. So you can see the slide. Hello?
Not yet. Not yet. You have to share your screen.
Yeah, I'm sharing the screen.
Dr. Sharath, help him.
And Tushar, I think there's some network issue. You are the co-host, so there is no problem in sharing as such. I think there is some network issue. Or have you opened the slide?
Yes, sir.
Have you opened your slide?
Yes, sir. Open the slide.
So just share it. It should come.
Tushar, when you actually press share screen, you will get a drop-down menu. From that, you should be able to select the PowerPoint.
Yeah, absolutely. Try. Can you
see the slide, sir?
Yeah, stop sharing, then again start sharing. Sometimes it happens. Stop sharing, then again you. Tushar, have you opened your slide or not?
I've opened the slides, sir.
Then you should go. No, we can't see your slide. You just go to the share again.
Share content, share screen.
Yes, share your screen.
Yes, sir. Yeah, I think.
No, we can't see your slide. Let me talk to the.
Yeah, I'll guide him. Tushar,
Yes, sir.
Please do that.
when you press the green button on share screen,
Yes, sir.
you will actually get a white
Yes,
drop
sir.
down.
There is written a drop down screen is written on it.
Can you see your PowerPoint on it? So move your cursor to the PowerPoint. Where can you see the PowerPoint written on that?
Sir, I think now I think I can do it. It's okay. Can you see the slides now?
Yeah, that's it.
Yeah. Thank you, sir. Thank you very much.
Perfect.
Yeah, and when you go on to the
Slides.
play, that's it. Fantastic.
So it's fine, sir?
Yeah,
okay.
It is fine.
So my topic is, sir, ultrasound guided central and peripheral venous access with the help of ultrasound. So ultrasound is not very old, as I said, neither it is very new. Since last 20 to 25 years, ultrasound is in the practice and people are using ultrasound for venous access in different procedures. But nowadays it has gained its popularity and almost everywhere people are using ultrasound. Maybe not in every procedure, but yes, in many procedures they are using. So before ultrasound, the central venous cannulation was quite full of complications. Around 15% of complications arise in blind procedures, and unsuccessful insertions were up to 12%. Recently, ASA gave their guidelines and they advocated that USG should be used, especially real-time ultrasound is very important for location and accessing central venous cannulation. Peripheral and difficult peripheral venous access also, ultrasound helps a lot. In pediatric patients, especially neonates, ultrasound may give good valuable assistance and they suffer lesser pricks. And of course, in critical care unit, they are a game changer. So the learning objectives in this session is central and peripheral venous cannulation, pediatric central venous cannulation, and recent practice guidelines of venous cannulation in context with the use of ultrasound. So ultrasound clearly demonstrate the following benefits that are, it shows the presence of vein anatomy and its patency. We can also have a good idea of puncture site and the angle of approach. It provides the real-time guidance. Guide wire placement within the correct vessel can be confirmed, and any complication can be diagnosed immediately. So are there any disadvantages? So in ultrasound, no, though there are not much disadvantages, but still we can say that it is a more complex technique and need a good hand-eye coordination. The limitations of ultrasound physics can cause errors such as reverberation artifacts. In small infants, when we are going for venous access, the physical size of the probe is a limiting factor, and the cost and maintenance of the ultrasound equipment. So to start with any intervention with the ultrasound, the first thing and the most important thing is to maintain sterility before and after the procedure. The American Institute of Ultrasound Medicine gave the guideline recently, and they say that for any intervention percutaneous procedures, ultrasound probe must be disinfected with a low-level disinfectant, and it should be kept in a safe place. So what are the prerequisites for USG guided cannulations? One should know the basics of USG. The resources should be available. That is, the surroundings should have the aseptic conditions. Equipments must be available. A checklist or a protocol for placement and maintenance of the cannula should be present. And you have assistants, especially qualified assistant helps a lot. There should also be enough measures to prevent infections and mechanical trauma. Mechanical trauma, by this I mean to say that the patient must, positioning and everything should be given prior to the procedure. And there should be a protocol or a guideline in a particular hospital to how to manage atrial trauma if it occurs. So the technique we just in short, as just taught in this previous session, 5 to 10 megahertz probe is used. It helps to locate the vein, ensure patency, and then we puncture. We can puncture blindly, but it is not much safer. It is just superior to landmark technique, but not very much safer. The real-time visualization of the needle going inside and popping in the vein and then traversing inside, that is the best approach. But still, at the end of the procedure, you need to do an X-ray to document. There are two, we can say there are two visual angles, that is transverse and longitudinal orientation. Transverse or short axis is easier for beginners. The longitudinal axis shows the vein, the full course of the vein, and we can see the entire course and the needle going in, or guide wire going inside the vein. With either needle tip cannot be seen if we are not in the plane. If we are out of the plane, then needle tip can't be seen. So what are the predictors of difficult cannulation? We are going for an USG cannulation, USG guided cannulation. So what are the predictors? So we can anticipate any difficulty during the procedure. That those are trauma, obesity, coagulopathy, intubated patient, patient in shock, hypotensive patient or hypovolemic patient, edema or hematoma, neck irradiation, or any previous difficult cannulation. There are two techniques for central venous access, static and dynamic technique. Static technique in this using ultrasound in 2 to 3 planes and mark with a pen, and then we go blindly. It is just superior to the landmark technique, but not very much safer than landmark. Dynamic technique, 1 or 2 person technique is there. 1 person, he himself holds the needle and the transducer. In 2 person, 1 holds the needle and 1 holds the transducer. But there must be coherence between them. This is the drawback of the 2 person technique. Image is used as a guide, and the real time we can see the needle tip going inside and popping in the vein. So for the internal jugular vein, it is large, easy to see. It is a good choice for beginners. The position is Trendelenburg and head rotated contralaterally to 30 degrees. Probe is placed transversely across the vein just above the clavicle between 2 sternocleidomastoid heads. And needle is introduced laterally from above the probe and just slightly towards the toes at 20 to 45 degrees. The real-time movement of the, in the real-time movement, we can see the needle, especially while piercing the vein with a pop-up. And, but we should always be aware of any anatomical variants. There is the possibility, always there is a possibility of such kind of variants, and we should be always be aware of such anatomical variants. So this is the figure which is shown here. This is the vein, and we can see the artery. This is the vein in longitudinal axis, and this is the carotid artery. So this is the short axis view in which the needle is going from in the center, and we can see the needle tip in the short axis view inside the internal jugular vein. In the long axis view, we can see the entire course of the needle just inside the vein. So this is another small video clip. See, we can see the needle, we can see the vein, collapsing vein, and the artery just lateral to it. And just now we are tilting the probe, and from short axis, it is going to long axis, and see the entire course of the vein can be seen here. Now, subclavian vein, it is more challenging to see the needle and vein at puncture site. But there is less risk of venous stasis, thrombosis, or catheter fracture. Probe is placed inferior to most lateral aspect of the clavicle, and the artery subclavian junction is punctured and close to clavicle. So this is the view showing subclavian vein and in the short axis and long axis. Yeah, this is the left side of the subclavian vein. We can show it. Yeah, the line just below, this is the pleural line. This is the compressible subclavian vein, and this is the artery. In color Doppler, you can see the pulsating artery and the subclavian vein and the pleural line just below it. Femoral vein, it is easy to perform. Transducer is placed along. If we are using the longitudinal view, it is placed above the femoral vein. Entire course of the vein can be seen. Needle is brought just below the probe and parallel to the transducer and vein. Sometimes Valsalva maneuver helps to distend the vein, and rotation of the external rotation of leg helps a lot. It moves the artery lateral to it and straighter the course of femoral vein. See, this is the left femoral vein which is shown, and in ultrasound vein, one is common femoral vein we can see, and the other where the vein disappears on compression. This is the Doppler color Doppler mode. We can see the vein and the artery, pulsating artery, and this is in pulse wave mode, and we can see the waveform, arterial waveform in the screen, and this is the venous waveform. So this is another way to confirm whether if we are in doubt or whether we are going at the wrong direction. So what are the reasons to failure in central venous cannulation? That is failure to identify the vein correctly or failure to locate the needle in the tissue. These are the two main reasons for failure in ultrasound guided venous cannulation. So then again, what are the tips of success? If the patient is awake, then we should check for the position, because always if we have done the preliminary ultrasound and we mark the position, and after that patient has moved, then during our approach, we may not find the vein in the right place. So we have to check the position. We can ask the patient to lie still, and then we can start the procedure again. Also, the vein should be in the center of the screen, in the middle of the screen, or we can say the vein should be lie between in the middle of the probe. Lighten the probe pressure. Do not press. Collapsing vein or patient in shock or hypovolemia, we may not see the vein because of even with the probe pressure. So that is the thing. Insert needle at the sharper angle, 45 to 60 degrees to intersect the vein. So steps for successful cannulation: use adequate gel, confirm orientation of the probe, do preliminary ultrasound, find a patent vein, mark the site. If we are going for static technique, we should mark the site and use local anesthetic. And the most important thing, sterilize the skin. Sterile probe and sterile technique should be used. Troubleshooting in a venous central venous cannulation, more than 3 failed attempts yields up to 6-fold increase in mechanical complication. This is a very bad thing, that more the failure attempts raises the mechanical complication. So everyone wants to do it in a lesser number of attempts in first attempts. So if we have cannulated the vein, then how to confirm it, whether we are in right place, or if we are in doubt, then what to do? We can attach a pressure transducer and see the waveform, venous waveform. And the other thing is blood gas analysis we can do and compare it with the known arterial sample of the patient, and then we can know whether our cannula is in right place or not. The finishing touch after the fixation, after the insertion, suture or adhesive fixation, which we always do, or even with our conventional technique, suture and adhesive fixation or adhesive fixation, sterile dressing, preferably a transparent dressing should be done. Care of USG probe, It is very important. It's not that we did the procedure and put back the probe without cleaning it or without removing the cover on it, and care of disposables and the instruments. So this is the finishing. So venous cannulation in a child, just to add on, there is not much difference between the venous cannulation in adult or in a child, but still there are consideration, because even whenever there is a child, there is always something special is attached to it. So the smaller size of the patient, greater mobility of some of the vascular structures. They are highly mobile with even with the heartbeat or with the respiration. Their mobility is increased. Smaller and more superficially positioned vessels, greater variability in the anatomy, potentially less cooperative patients, and smaller size of the equipment. So in a child, brachiocephalic vein is preferred many times because of its own advantages. So visualization of the needle along the entire path is one thing. It provides superior patient comfort. There is ease of dressing in brachiocephalic vein in children, and upper extremity movement is not hampered. So if we go for subclavian approach, subclavian vein infraclavicular approach, then there is some upper extremity movement restricted. But in this brachiocephalic vein supraclavicular approach, there is not much hampered. And since it is not hampered, dressing remains in the position, it does not come out, and the contamination of the central line does not happen. So there is less chance of infection also. So this is the probe position and needle insertion point in the brachiocephalic vein. And this is, you can see, this is the internal jugular coming from above, and this is subclavian vein coming, and this is the needle we can see going into the brachiocephalic vein. So for a child, the bottom line is the most important things for success or failures are our choice for site of cannulation, ultrasound technique, the size and condition of the child, operator's experience, a presence of any vascular anomalies, and coagulation abnormalities. So this finishes central venous cannulation. Now we come to peripheral venous cannulation. The basics are same. For the prerequisites are almost same. That is, we should know the basic knowledge of ultrasound and guided vascular cannulation. We should select superficial veins. A patent vein should be there. Vein size should be preferably more than 4 millimeter of vein, and depth not more than 16 millimeter. Either we can choose in plane or out of plane technique for insertion, and check catheter position after insertion. So points to keep in mind is that superficial veins superficial veins are preferred because they have a short pathway, easy access. Deep veins disadvantages, such as they have a risk of needle stick injury in the artery or nerve, and there is frequent catheter dislodgement. The lumen should be anechoic and fully compressible. The AP diameter should be more than 4 millimeters. And as a rule of thumb, 4 millimeter diameter corresponds to 4 French catheter, not more than 4 French. So 4 millimeter vein is for 4 French catheter. And the real distance to reach the vein is 1.4 in the vertical distance. We will come to it. And confirmation can be done by either direct confirmation or indirect confirmation. Direct confirmation is a double hyperechoic line can be seen in the lumen, or indirect confirmation is by saline flush test. This is just a figure showing veins in the upper limb and central veins, and their ultrasound, how they look on USG. So this is venous cannulation in the forearm. This one is out of plane, that is in short axis or transverse axis. We can see the vein and the needle just popping inside the vein, and in long axis, the needle, and the course of the needle is going inside. So we can see that they have both the things have their own advantages. So whatever you choose to go in, you can proceed. So this is the figure in showing short axis or long axis view of vein. And then the D is the distance of probe to the vein. And the real distance that is the cannula needs to travel to reach the vein is 1.4 into D. This is at the angle of 45 degrees. As we increase the decrease the angle, more is the distance. So this is the thing we can see here. The vein lumen we can see, and the diameter of the vein lumen we can see it is 4.3 centimeter, and the distance from the skin is 2.1 centimeter. So the real distance is 1.4 into 2 is, that is 2.8 centimeters. This is in PW mode, so showing the venous waveform, and we confirms that it is a vein. So this is the one of the we took here. We can see the red arrow is artery, and the blue arrow is a vein. And in we can see the pulsatile waveform in the artery. And when we go to the vein, there is no pulsatile movement. See, this is the straight line coming on. And now we go for, if we do it color Doppler, then there we can see the pulses, pulsatile movement in the artery, but there is no pulsatile movement in vein. See, upon compression also there is no compression in the vein and artery. There is slight movement, but there is no compression in the vein. This is the thrombosed artery. So we can know, we can ultrasound, we can also see the thrombosed artery, and where not to go, where to go, we can decide it. So this finishes peripheral venous cannulation, and we come to the guidelines. Recently, ASA gave a guideline in 2020, and they say that a real-time ultrasound should be used for placement of the, during the placement of the needle, while insertion of the needle in the vessel, and while inserting the guide wire, and finally while confirming. So in internal jugular vein cannulation, they say that yes, it is a must and it is the standard of care. For subclavian vein and femoral vessel cannulation, they say that yes, it can be used and it should be used and it is good. But for internal jugular vein, they have specified separately for internal jugular vein that it should be used, it must be used, like this. So this is the summary. They use real-time ultrasound while insertion, then venous when it is in vein, then confirm it with the ultrasound. Then if the guide wire is placed, then it should again be confirmed with ultrasound. So this is the guideline that says that USG should be used for central venous cannulation, and in these 3 points specifically, they must be used. So to finish up, just a touch, COVID-19 and venous cannulation. This article was published in JAMA in 2021 January. And they say that subclavian veins were discouraged, even given the known fact of increased incidence of pneumothorax compared with internal jugular vein. This is written in context with COVID patient, and due to frequent use of prone positioning in patient with COVID-19, placing a triple lumen catheter in the popliteal vein under ultrasound guidance is a good option. So this is another good thing, that popliteal vein can also be cannulated if the patient is prone and we don't have much option, then we can cannulate the popliteal vein for central venous access. So this is how they are doing it. This is the right lower limb showing popliteal vein, just below the tibial nerve and above the popliteal artery. So to finish up, today, there is a lot of result-oriented people are there. Patient is also result-oriented, and doctors and management is also very result-oriented. They want quick results in lesser number of staffs, lesser number of doctors and nurses, and they want less complication and faster recovery or faster results. So ultrasound gives a very good option for this kind of demands. But before using ultrasound, sterility and proper positioning is a must, and it should be done. It is a vital aid in central venous and peripheral venous access procedures. 40% of resources are saved when ultrasound is used, and we must know the basic landmarks and anatomy. We should not directly jump to the ultrasound use of the ultrasound on patient. We should know the basics, and then we should go for ultrasound venous cannulation. Thank you, sir.
Yeah, Dr. Shiv.
Thank you, Tushar. That was a very nice presentation.
Thanks.
And I think you covered quite a bit of the whole of central venous cannulation and peripheral venous cannulation as well. The last part of the thing about using a popliteal vein in COVID was a little intriguing, because how do you actually miss the nerve? Because the vein actually lies, unlike in femoral area where they're lying side by side, the vein is actually lying under the nerve. So how are you
Yes,
going to avoid the injury to the nerve if you're going it? So you need to be actually careful. You need to scout the vein and find out where the vein is actually lying by the side, okay, in between. So you need to be careful with that, because your image actually showed very clearly,
Yes,
that vein is lying between.
Yes.
You will not actually attempt to go into the vein, whether you are out of plane or in plane. You are not going to go.
Yes.
I don't know if there are any questions we have from them.
Yeah, there are no question in the chat box, but still we can.
Are there questions from the audience, because this is a webinar? So anybody keeping eye on questions from the audiences, other audiences other than who are in here? No. Okay. So again, now you talked about the venous cannulation, real time, right? I think what they meant by real time is that you actually see the needle, okay, going in, then people actually then stop. So what they do is once people actually get the blood into the the needle, they just leave the probe and then put the guide wire in, and then once the guide wire in, they scan again and do it.
Yes.
But it's quite possible to actually still counter puncture, because one thing you have to remember, that when you're actually applying pressure, right, the needle can actually, as you release the probe, the needle can come out. This is very true where
Yes.
the vein is actually very, very superficial. So displacement can still occur. So what I actually teach now, my registrars, if you look at these catheter sets, they actually come with two types of needle. One is a complete big metal needle, which most people use. That was actually better for if you're doing a blind technique. Okay, that is okay. You actually feel and you actually just go in and then you are, because you don't leave that pressure. Okay, but if you are actually wanting to actually use the ultrasound, then there is another needle. It's a green needle. It's like a catheter, like Gelco catheters. Okay, they don't have flanges. It's simple. Use that. You don't even have to actually attach a syringe to it, right? You can do the whole thing. And once the needle has gone in, you just thread the plastic part in. Okay, take the needle out. Then there will be no counter punch and nothing goes anywhere. And then you can also do a real time. You can actually put the probe back and you can actually see the guide wire. Okay, in the long axis, in the longitudinal view.
Mm-hmm.
Okay, that is the safest way of actually doing internal jugular, or for that matter, any kind of cannulation. Okay, so I think that's rest of the thing I think it's the same. Where are you going to use it? Very few people actually use the subclavian, but subclavian cannulation is not very difficult. Again,
Yes.
you just need to be a little more lateral. You might be actually going towards the territory of the axillary vein. But how does it matter? In the end, the guide wire is going to go into to the right atrium. It will follow the course, so it is actually fine. I've done for the dialysis catheters, because that's actually or hemofiltration catheters. You can do that. Femoral at times can be tricky, your guide wire. Okay, so you are easy to actually see the femoral vein, but sometimes the guide wire doesn't thread.
Yes.
Okay, because here, yeah, the way it dips under the vein dips under the inguinal ligament, it can sometimes be difficult. So yes, external rotation of the leg actually sometimes actually helps in that. Peripheral vein, again, I think very good points. Actually, I think you mentioned how to measure the depth. In the peripheral veins, the place where you will use ultrasound is where they're going to be difficult access. So you are actually going to go for a deeper vein. You're not going to go for superficial vein.
Yes.
Superficial vein, if they're seen, anesthetists are very good at getting them. So it actually happens. So we get drug addicts. You will not find any superficial veins in them. You have to go for the deeper vein. And one of the problems with deeper vein is that you don't get enough length of the cannula.
Yes.
Yeah. The length is always a problem. So in that, I would actually suggest that if you actually don't have special kits, okay, use a 18G radial arterial cannulation. They are longer.
Yes.
Okay, they are good. And second thing, they don't kink at the hub and the catheter. That is the weakest point in any cannula. So if you're using a normal Venflon, they will actually, because it's going at an angle, the way once you actually stick the tapes on, it will kink and there will be no flow in it. You may be able to inject drugs, but you won't see that there's a free flow of fluid. So if you're having a problematic patient, if you don't have long cannula, just use a 18G arterial cannula. Those are longer. So the femoral cannulas, which are used for arteries, they are actually good ones to actually use for deeper veins in these patients. I think that's from my side. Yes, we talked about parts in the nerve blocks. Here, forget, it's not a part, it's an art. Okay, no P. So no P in the parts, it's just arts. Pressure is actually not required. You need to be very gentle when you're actually doing venous cannulation. And the same people who actually moved from doing cannulation, when they move to doing nerve blocks, they forget to apply pressure. Okay, so they need to actually do the opposite. So these two are slightly opposite. Rest of the things are similar. Thank you. Shall we move on to the next talk then?
Dr.
Yes.
Tushar,
Yes, sir.
very nicely presented. How many success rate for cannulation and the nerve block procedure in your institute? Actually,
sir, I won't say about the nerve blocks because in anesthesia department still we are in demand of ultrasound machine. But yes, we have critical ultrasound machine in our critical care unit, and we are using enormously, extensively. We are using for last 2 years at least, 2.5 years. We are using it, and results are good. Yes, sir.
I think most central line cannulations are now done with ultrasound. I think most people will.
Yes, sir. In our CCU, we are using it.
Any other questions from the members before we move on to the next talk?
No, thanks. Good.
Yes.
Dr. Shiv, may I ask you one question?
Yes, please.
What is your take on the use of jelly? Because if you use a lot of jelly and it is not cleaned while insertion of the cannula, you can take bit of it into the central vein and maybe a reason for thromboembolism or whatever it is. I don't know, it's a very real danger, but this is one of the probability.
So it comes in our kits actually come with sterile jelly. It's part of the kit, but also we actually have small sachets of sterile jelly. So never use unsterile jelly. That's one thing. So if you don't have access to jelly, all you need is a interface. So you can even use like water or saline. You can use that.
Yes.
Yeah. So once you're there, so you just need some kind of interface. So the cover, inside the cover, you should always apply gel. So that gel can be, because you're going to cover it with a sterile probe, the cover, so that's not a problem. But if you're actually applying on the patient, it's a sterile gel. It has to be sterile, whether it's within the kit. So the new kits, we have the packs, they are now coming with gel. The old kits never used to come with the gel. Now the new kits are coming with gel. Or if not, you actually get this Optilubes, small sachets. They are sterile gels. So they're not very costly. They're water-based. So because they're water-based, they're not actually any harm. They will dissolve. That's it. You might embolize a little bit of it, but they do not cause any harm because they are water-based.
Yeah, it's okay. So now we can move on to the next speaker.
Yeah.
And the next speaker would be the Dr. V. Mohan Kumar from Muzaffarpur. And I think he'll be speaking on the role of ultrasound in the intensive care unit or critical care unit. So yes, Dr. V. Mohan Kumar.
Is my slide visible?
Yeah, visible.
You converted to slideshow. Yeah, it's okay.
Thank you, Dr. Sharath. Thank you, Dr. Sharath, for inviting me for this lecture. I received a warm welcome from you in Patna, and this is a great opportunity for me. Thank you very much. So, it's a great dream tool for all the intensivists. I heard Dr. Tushar saying that he is using this ultrasound machine for last 2 years, and I'm sure he will be harvesting fruit of his hard work in last 2 years, because you can do this ultrasound on bedside. It's a real-time imaging, and it helps in making decision. You don't just do a ultrasound to see whether there are cysts in kidney or not. These are critical findings to be done on the bedside, and you get immediate results. So it helps in decision making. So the first part I will be considering is the lung ultrasound. Lung ultrasound relies on the interpretation of artifact as well as direct visualization. It's a great diagnostic tool with very high diagnostic accuracy. And the best thing is that it has a very steep learning curve. I mean, 1 or 2 days are enough for anybody to learn lung ultrasound who is into ICU. The lung ultrasound is based on 3 basic principles. Principle number 1 is that air and water occupies opposite location or are intermingled because of some pathological process which produces some artifact. The second principle is most of the signs we discuss in lung ultrasound, that is A line, B line, C source, and all of them start from the pleural line. And this pleural line is nothing but the parietal pleura. And the third and the most important thing we have to remember is that ultrasound waves cannot penetrate through the air-filled space and are reflected back. So what it means is that, I'm really sorry. What it means is that the structures below the pleura cannot be visualized in a air-spaced lung, and only artifacts will be produced depending on the amount of air and fluid inside. So on one side you have, full of air, that is, you think of pneumothorax, where only artifacts will be seen. And on the other side, you get pleural effusion, which is directly visualized. And in between these two extremes, that is pleural effusion and pneumothorax, there are different situations like, say, normal lung, which contains about 98% of air, or interstitial syndrome, which contains, normal lung contains about 98% of air, interstitial syndrome contains about 90% of air, alveolar syndrome, which contains about 10% of air, and hardly contains any air. So you have to recognize the pattern seen on the ultrasound, whether you are seeing a air-filled space or a pleural effusion or a pattern which is similar to that seen in interstitial syndrome or atelectasis. I will come to these things. So this is the first case I will discuss. This is a patient presents in emergency with 3 days history of fever, cough, and progressive dyspnea. His saturation was 78%. Room air X-ray showed bilateral diffuse infiltrate, and diagnosis of ARDS made. Patient shifted to ICU and put on ventilatory support according to ARDS net protocol. Patient saturation gradually improved in next 4 hours, 94% with FiO2 of 80%. Tidal volume 300, PEEP of 10, and respiration rate of 12. A baseline lung ultrasound revealed this picture in the right lower anterior point. So here you are seeing a sign. What you are seeing here is that these are the rib shadows, the cortex of the rib which is shining, and these are the rib shadows. And this is the pleural line. And from the pleural line, what we are seeing is that these are sharp white lines which are originating from the pleural line and reaching the bottom and are moving with the pleural line. So this movement of pleural line, along with this movement of these B lines, these are called the rocket lines or the B lines, which are seen in patients with interstitial syndrome. Now, this interstitial syndrome produces B lines because there is a juxtaposition of air-filled alveoli with thickened septum. Now, this thickening of septum can be because of fluid or because of fibrosis. So you can get this similar pattern if a patient comes with lung contusion. You can get the similar picture if patient is having pulmonary edema. You can get the same picture if patient is having pulmonary fibrosis also. This pattern is important to recognize. Say patient has come to you with trauma of 2-hour duration, patient will not develop this kind of ARDS in 2 hours. Probably we are dealing with a case of contusion. If a patient of heart failure presents like this, you think in terms of pulmonary edema, right? So the pattern is important to recognize. So this pattern is that of an interstitial syndrome. Now 12 hours, patient was put on ventilator. However, 12 hours afterwards, patient again started desaturating with saturation of 64%, hemodynamic instability, and ventilator showing increase in peak airway pressure. What cause would you consider? A bronchospasm, a collapse, a fluid overload leading to pulmonary edema, or something else? Now, what you are seeing here is that the B lines have gone completely. The B lines have gone completely. And what you are seeing here is this is the pleural line. And at the equidistance from the skin to the pleural line, you are getting a shadow here. So these are called the A lines. Now A lines are reverberation artifacts of the original pleural line. So within 12 hours, patient will not improve as far as ARDS is concerned. So what has happened to the B lines? Probably patient has developed pneumothorax. So if you are getting a absence of B lines in quick time, you think in terms of pneumothorax. If you are getting B lines, it rules out pneumothorax. In a patient with B line, all of a sudden, if the B line disappears, you think if the patient is particularly on ventilator, you think of patient has developed atherogenic pneumothorax. So A lines you get in normal lung as well as in pneumothorax. B lines you get in patient with interstitial syndrome. Now, the third case I will discuss. This is a 45-year-old gentleman presented with 3-day history of fever, cough, and shortness of breath. Lung ultrasound revealed the following picture. So what you are seeing here, you can appreciate that this is diaphragm, this is liver, and above diaphragm, you are seeing a structure which is looking almost similar to that of liver. This is called as tissue sign, where this is called the hepatization of lung has taken place. Why? This is basically a alveolar syndrome. What is alveolar syndrome? You know, the alveoli, the contiguous alveoli are filled with fluid and they are contained in a interlobar septa. And this structure of fluid filled alveoli along with the septa forms this kind of picture. If it is taking at a lower level, we call it a translobar consolidation. Also, if you look carefully, you are seeing these whitish areas here. These are white areas. These are white lines here, here, here. These are white lines. So these white lines are nothing but dynamic air bronchogram. Now, you see similar kind of picture in collapse also. But You can get some air bronchograms in collapse also, but they will not move. Presence of dynamic air bronchogram is a sign of consolidation. So here you are seeing the air bronchogram, which is confirming, which is moving with respiration. So it is confirming a diagnosis of consolidation. Apart from this, you can also see the normal, see these are serrated margins along the consolidated areas. So these serrated margins are telling that there's a difference. This is a margin between the consolidated lung and the normal lung. So we have discussed A line, B line, and the tissue sign or the alveolar syndrome, which are the three commonest cases we see in our ICU scenarios. Now, before I go to the echocardiography, I want to present one case. Is that of a traumatic brain injury patient who came in emergency with GCS of E3, V3, M5, CT scan revealed diffuse external injury and small subdural hematoma in right parieto-temporal region. He was put on ventilatory support. Patient was stable until day 5. The resident doctor informed a decrease in GCS to E2, V2, M4. So there is a decrease in GCS by more than 2. In spite of normal hemodynamics, pupil shows sign of anisocoria. What will you do? Will you take the patient for CT scan, or will you do a invasive ICP monitoring, or can you do something which will give a earlier interpretation of raised intracranial pressure? So this is optic nerve sheath diameter measurement by the linear probe, where this is the terminal end of the optic nerve here, and from there you go 3 millimeter down and measure the optic sheath diameter from the outer part, not from the inner part, from the outer part. And if this length is more than 5 millimeter, the sensitivity and specificity is more than 90% for a raised intracranial pressure in a patient who is predisposed for developing that. There may be some limitation, like patients who are having optic atrophy or acute optic neuritis or Graves' ophthalmopathy. But in general, if you are doing optic nerve sheath diameter, you can quickly interpret or assess the sudden rise in intracranial pressure. It can also be used to monitor the intracranial pressure over a period of time. So whether you are giving mannitol and 3% saline to the patient and you want to see whether the ICP is decreased or not, so you can use this method. This is very easy, convenient, can be done at the bedside, and again, the learning part is very steep. Now coming to the echocardiography. Now, echocardiography is to me the tool. I started learning my ultrasound by starting with echocardiography. And in the last 10 or 11 years, as I am working in ICU, there are few questions in an unstable patient who comes to my ICU always creeps up in my mind. What is the circulatory status of the patient? Is the preload sufficient to achieve or not? Is the preload sufficient to achieve the cardiac output or not? And does patient require fluid, or we have to reduce the fluid level? I mean, we know that we have to resuscitate the patient, optimize the patient, stabilize the patient, and then you have to de-resuscitate the fluid level from the body. So all these things, and then what is the cardiac functional status of the patient? Also, can we wean this patient from ventilator? And if yes, how early we can wean this patient from ventilator? So these questions can be answered with echocardiography if done in a judicious way. Now, see, this is no brainer actually. Here we are dealing with a case. This is a patient who came with a blood pressure of 90/60 with 2 days episode of fever, burning maturation, and you just interpret that this is a 4-chamber view of heart where you are seeing the left atrium, left ventricle, right atrium, and right ventricle. All you have to see here is that the two walls of the left ventricle are almost kissing each other. So this is a small ventricle and this patient requires fluid. So hyperdynamic heart with small ventricle is nothing but hypovolemia. You have to pour in blood initially as part of resuscitative measures. So just see, the point of care ultrasound do not recommend using and measuring stroke volume or ejection fraction. just eyeballing is enough in most of the cases. So small ventricle, hyperdynamic, the kissing each other. You see the two walls are almost kissing each other. So this is a sign of frank hypovolemia. Now, we know that in a case of positive pressure ventilation, during inspiration, the preload decreases and the afterload of right ventricle is increased. So if a patient of hypovolemia comes, during inspiration, the stroke volume will decrease because of decrease in preload and increase in afterload. The effect is more on preload if patient is hypovolemic. But say, for example, if patient is having a case of acute pulmonary embolism, then the effect of ventilator is more on afterload of right ventricle rather than on the preload part. That's why I have posted this video that if suppose this patient comes to you, this patient will also be having a stroke volume variation. If you are using this PICO or LITCO, this patient will be having stroke volume variation. But here you are seeing a enlarged right ventricle. Now this enlarged right ventricle, in that case, the afterload is increased. If you pour more blood in this fluid in this patient, that will result in a case where the right heart failure will lead to left heart failure because of pushing of septum to the left side. So not all patients who are showing stroke volume variation are having fluid deficit state. That you have to remember. Now, you want to know what is the cardiac output or what is the stroke volume or how is the systolic function of the heart. The best method according to me is VTI. VTI basically tells you that during one contraction, how much distance the blood has gone from the ventricle. So you try to make a 4-chamber view by putting a probe just below the left nipple, the 5th intercostal space medial to 1 centimeter medial to the mid-clavicular line, and you will get a 4-chamber view. And if you tilt the probe slightly towards the sternal angle, you make a 5-chamber view where you are seeing the opening of the aortic valve. Now you have to put a pulse Doppler in the left ventricular outflow tract, and you will get a wave which is negative because the probe is here and the blood is going in this direction. So you will get a negative. Wave. So you just have to use your pencil skills to measure this, and you will get a VTI. If you are getting VTI variability, so it is reasonably sure that patient is having hypovolemia. But remember one thing. Again, I am saying echo is telling you not only about the fluid responsiveness or how the good is heart function. It is telling you the exact cause. Whether you want to say, for example, if patient is having pulmonary embolism, then also you will get this VTI variability. But there you don't have to give fluid. So you have to correlate many things. So VTI variability is a sign of fluid deficit. You have to give fluid in this kind of patients. Now, this is again another case where patient comes in emergency following a trauma and now he is in shock. You did the EFAST part and you are seeing a case of this is a case of cardiac tamponade. You see the collapse of RA and RV. So during systole, the RA and RV are collapsing. Both during systole and diastole, actually, you are seeing the collapse. So this amount of fluid, if they see the tamponade depends not only on the volume of fluid, it depends on the duration. I mean, whether the tamponade, whether the fluid accumulation has occurred very quickly or not. If that is the case, then there is no other option but to go for pericardiocentesis. See, again, I am saying what we are saying and doing here is that these things allow you to make quick decision at the bedside of the patient. So this is a case of cardiac tamponade. Patient has come with low BP. You did the echo, did pericardiocentesis. Patient is almost normal. Now from echo, let's move to this fast evaluation. Now we know that particularly in trauma patient, if patient comes in an unstable condition and the fast is positive, patient goes in OR. So this fast evaluation helps in decision making, right? So
In this soundbites module, we'll continue.
So in this evaluation, we are basically doing the right upper quadrant, left upper quadrant, and the suprapubic area. And all these three things, apart from the evaluation of the pericardium and looking for pneumothorax, makes the E-FAST evaluation. So these patients who come with trauma, you have to do E-FAST for early evaluation of any instability as far as abdominal and chest injury is concerned. Now, what you are seeing here, so this is liver, and this is kidney, and this is diaphragm. Now, this is a normal evaluation, and then we go for look at the texture of the liver, and there is fluid just below the diaphragm. So there is blood in the peritoneum, and here you are seeing the Morrison's pouch. Here you are seeing Morrison's pouch. There is blood in the Morrison's pouch, which is almost continuing with the right paracolic gutter. If this patient is unstable, there is no doubt that this patient goes in OR. Similar findings, if patient is having again fluid in the left upper quadrant, that is in the rhinosplenic space, or if there is intraperitoneal rupture of bladder where fluid goes into the pouch of Douglas, then also patient goes into OR. So again, I'm repeating, your ultrasound skill has made a decision rather than waiting for the surgeon or a radiologist to come and make decisions for that. Now, the other uses for me in ultrasound are TCD, which I use rarely, then blocks, these rib fracture patients. Rib fracture patients, if they are on ventilator and you want to take them out from ventilator, you must provide pain relief. And what better pain relief than using ultrasound guided paravertebral blocks? I often use these paravertebral blocks in patients who are having rib fracture on ventilator, and believe me, it helps in winning these patients quickly. Now, tapping of the pleural fluid. Many times these patients who are having heart failure, who have chronic heart failure, comes with acute exacerbation of heart failure, and they have massive pleural effusion. So you relieve the pleural effusion and the work of breathing decreases. Now, before I finish my slide, I will point out one more thing. That I said that I have deliberately not figured out the inferior vena cava, because now inferior vena cava is not considered a good marker for hypovolemia. But in general, if you are dealing with a small heart, patient is hyperdynamic, and you can do the stroke volume variability or with that VTI variability. So you can assess. You can also do passive leg raising and then again evaluate the VTI to look for fluid receptors. When to stop the fluids. Now, one way is to look for B lines in the lung ultrasound, where if you are starting seeing the B lines in the basal area, this is for you to stop the fluids. But even before that, if you start pouring in fluid, the compliance of the left ventricle will decrease. The decrease in the left ventricle compliance is the first sign that now this patient is having increase in the left ventricular diastolic pressure. So if you can assess the diastolic function of the heart, so that helps. If there is increase in the diastolic dysfunction, so probably to me this is the first sign of stopping the fluid. And if again patient is hypotensive, then you think of vasopressors or anatropes based on how the left ventricle is working. So with this, thank you very much. Wishing Indian team success today, but I don't think they are going to win. They have lost too many wickets. Thank you.
Thank you, Dr. V. Mohan. It was excellent and very brilliant talk, covered almost all the aspects of the intensive care use of ultrasound. And may I now ask the participants to ask questions, if they can ask directly or in the chat box. I do not see any question in the chat box. And Dr. Shiv, anything to add, or if no questions, then we can
the screen, Vimon.
Yeah. And Dr. Mohan, please stop sharing.
Okay.
A very good lecture, extensive, but I think that was actually assuming, I think you are assuming that this lecture is to someone who actually already knows what POCUS is or ePOCUS is, eFast is. You need to actually know your audience better. And like, for example, I think it would have been very useful if you actually had told the audiences, like when you're discussing about the lung science, where you're putting the probe, how you're putting the probe. I think those are very, very important things for people who actually do not use this modality routinely. I think otherwise, I think for people who understand what these, you don't have to start sharing, Mohammed. Mohammed, we're still discussing. You don't have to start sharing yet, but we can leave it. Don't worry now.
Dr. Mohammed, please stop sharing.
It's okay. It's okay. It's okay.
Dr.
He's in a rush. Well, I think he's just testing whether he can share or not. It's fine. It's fine. I think the other things I think very well covered, like you discussed about the optic nerve diameter. I think that was a good case to actually discuss. Echocardiogram, you did actually mention about how to actually get 4 chamber views, but I think a little bit more on, parasternal, long axis, short axis, apical view, xiphoid view. Those also would actually add a little bit to the, just I think making people understand that these are good, because this is actually a great thing which is actually coming out well, and especially just few weeks back this was presented at the trauma meeting, which was organized by the armed forces, the medics, and there we actually discussed that. But I think a lot of people do not still have access to ultrasound, but it is still asked in the exams. So there are postgraduate students. So just showing them where you put the probe, how you put the probe, that would have been very useful. The other thing you talked about, IVC. IVC is still actually not in intensive care. So this is not intensive care, but still used in the A&E. It's still used in the theaters. Before patient actually you put to sleep, you put the probe, subxiphoid, looked at the IVC, look at the diameter of the IVC, ask them to take a deep breath, see how it is there. So it is still used. It's may not be used in the intensive care, but it is still used in the anesthesia practice. But I think your lecture was on intensive care. So that's a fair point. I think you have better ways of looking at volume responsiveness in intensive care. I think otherwise, beautifully presented. Thank you. Thank you for presenting.
Thank you, sir.
Yeah,
So
with this note, I think, we can move on to the next speaker.
Yeah.
So our next speaker is Mohammad Nasrul Bari. He is senior resident from the Katihar Medical College, and he'll be speaking on the ultrasound guided regional anesthesia for the upper limb. Yeah, Dr. Bari, you can go ahead.
Am I audible, sir?
Yeah.
Yep. You can go on to the slideshow, the whole screen slideshow. Just go on slideshow. Yeah,
okay.
That's it. Very good.
Good evening to everyone. Am I audible, sir? Hello.
Yes, you are. Yes, you are. Okay, continue,
yes,
please.
you are audible.
Yeah.
Okay. Good evening to everyone. My topic of presentation is USG guided regional anesthesia for upper limb. First, I am introducing myself. Myself, Dr. Nasrul Bari. I have done my MBBS and PG diploma anesthesia from JNMCH, Aligarh, and secondary DNB anesthesia from Fortis Hospital, Noida. At present, I am senior resident in Katihar Medical College. Now coming to my topic. As I have described, my topic is regional anesthesia for upper limb. So for regional anesthesia for upper limb, following nerve to be blocked. First is brachial plexus block and terminal upper extremity nerve block. such as radial nerve, median nerve, ulnar nerve, and musculocutaneous nerve. First, coming to the brachial plexus block. And before going to the brachial plexus block, we first know the anatomy of the brachial plexus. So first, anatomy of brachial plexus. Brachial plexus is formed by anterior primary division or ventral rami of the C5 to C8 and T1 nerve with variable contribution from C4 and T2. So root value of brachial plexus is C5, C6, C7, C8 and T1. But sometimes C4 and T2 also contribute. Brachial plexus consists of root, trunks, division, cord, and terminal branches. So location of root is between the scalene muscles. Scalene means here anterior scalene and median scalenus medius and scalenus anterior. The trunk is lie in the posterior triangle, and the division of the brachial plexus lies behind the clavicle, and cord arranged around the second part of the axillary artery. In 10% of the 10% people, plexus are prefixed, and 10% people have postfixed. What do you mean by prefixed and what do you mean by postfixed? Prefixed is, as I know, the root value of brachial plexus is from C5 to T1, but here the root value is from C4 to C8. T1 is missing here, and in postfixed, starting the root value is C6 to T2 instead of C5 to T1. Now here coming to the root value of the brachial plexus C5, C6, C7, C8, T1. C5, C6 root combine to form superior trunk. C7 alone make medial trunk. C5, C8 and T1 make inferior trunk. All the three trunk have two division, anterior division and posterior division. Anterior division of superior trunk and middle trunk makes lateral cord, and anterior division of inferior trunk alone makes medial cord, and all the three division, posterior division makes posterior cord, and all the lateral cord has 3 branch, posterior cord has 5 branch, terminal branch, and medial cord has 5 branch. Just know the mnemonic. For lateral cord gives 3 branch. Mnemonic is LML, lateral pectoral nerve, musculocutaneous nerve, and lateral root of median nerve. And for medial cord, total 5 branch. Just mnemonic is M4U. M is medial pectoral nerve. Second M is medial cutaneous nerve of arm. Third M is medial cutaneous nerve of forearm. Fourth M is medial root of median nerve. And last one is U. U is ulnar nerve. For posterior cord total 5 branch. Mnemonic is ulnar. U for upper or superior subscapular nerve. L for lower subscapular nerve or inferior subscapular nerve. N for nerve to the latissimus dorsi or thoracodorsal nerve, and A for axillary nerve, R for radial nerve. This is the anatomy of brachial plexus. Now coming to the approaches for brachial plexus block. There are mainly 4 approaches for brachial plexus block on the basis of site. Interscalene brachial plexus block, supraclavicular brachial plexus block, infraclavicular, and axillary on the basis of site. And the technique generally used is for brachial plexus block is either paresthesia technique or landmark technique. Second is peripheral nerve stimulation technique. And third one is ultrasound guided technique. My topic is ultrasound guided, so I am focused on ultrasound guided, but slightly also elaborate paresthesia technique and PNS technique also. Now coming to the ultrasound guided technique. First, we know, before going to the ultrasound technique, we know which nerve block requires which probe. So there is mainly 2 types of probe. One is high frequency transducer and other is low frequency transducer. High frequency transducer example is linear probe, and low frequency transducer is curvilinear probe. High frequency generally have high resolution picture but poor tissue penetration and therefore used for superficial nerve. And low frequency transducer have poorer image quality but better tissue penetration used for deeper structure. So when we block the superficial nerve, we use linear probe, high frequency probe. And when you use deep nerve that is deeply placed, we use low frequency transducer. Suppose that we block sciatic nerve. Sciatic nerve is very deep, so we use curvilinear probe. And when we use brachial plexus block, radial block, nerve block, etc., we use high frequency transducer. And another one thing we have to know is in plane and what is in plane and what is out of plane. In plane is also known as short longitudinal axis, or uh, uh, in plane. This is in plane technique, and this is out of plane technique. In plane is also known as longitudinal axis or long axis view, and out of plane is also known as short axis or transverse axis view. When we place the needle in long axis view, it is parallel to the probe. Introducing needle is parallel to the axis of the probe, and in this whole shaft is visualized, where when we use the needle in transverse axis view or short axis view, only just the needle tip is visualized. Advantage of ultrasound guided nerve block is it provides direct visualization of nerve and surrounding structure, and it provides direct visualization of speed of local anesthetic injection when we given the local anesthesia, and also it avoids the side effects such as intraneuronal and intravascular injection. When both it can intraneuronal injection can cause nerve injury, and intravascular injection can cause local anesthesia systemic toxicity. So ultrasound will avoid use of ultrasound is avoid this side effect. Avoidance of painful muscles contraction during nerve stimulation, because when we use nerve stimulator technique, there is lot of very high muscles contraction is seen. In case of fracture, the use of peripheral nerve stimulator is painful for the patient. And third advantage, and another advantage is reduction of the dose of local anesthesia, faster sensory onset, longer duration of block, improved quality of block, and patient comfort. Now, first coming to the interscalene block, as I have already described the fourth technique of the brachial plexus on the basis of site: interscalene block, supraclavicular block, and infraclavicular brachial plexus block, and axillary block. Interscalene, just we note where is the interscalene group and where we have to give interscalene block. This is the cricoid at the level of cricoid C6, at the level of C6 vertebra. There is cricoid cartilage. Lateral to this, first structure is medial head of sternocleidomastoid, then lateral head of sternocleidomastoid, then anterior scalene, then medial scalene muscle. The anterior scalene and medial scalene, between anterior scalene and medial scalene, there is internal. This is a scalene group at the level of cricoid cartilage. This is the site of interscalene block. Indication of interscalene block is, major indication is shoulder surgery, since block is most intense at upper and middle trunk. But one disadvantage of this block is inferior trunk is often spared, and ulnar block is ulnar nerve is spared. So for a lower at the wrist or hand surgery, the just ulnar side pain. When we use paresthesia technique or landmark technique, patient is placed in supine position with head turned slightly to the contralateral side. Posterior border of sternocleidomastoid is palpated by having the patient briefly lift his head. Interscalene group is palpating by rolling the finger posteriorly from this border over the belly of interscalene muscle into the group. A line is extended laterally from the cricoid cartilage to intersect the interscalene group, indicating the level of transverse process of C6 vertebra. Using sterile precaution, local anesthetics is injected at this point, and skin wheel is raised. A 22 to 25 gauge, generally 22 gauge is used, and 4 centimeter either or 5 centimeter needle, generally insulated needle is used when PNS technique is used, because they insulated needle prevent the spread of current. into the perpendicular to the skin and advance in slightly medial and caudal direction until a paresthesia or evoked muscle contraction in arm is elicited. After appropriate paresthesia or motor response is obtained, the needle is stabilized. After negative expansion, 10 to 40 ml solution is injected. Digital pressure above the injection site and downward massage along with a 45-degree head up position may facilitate caudal speed and block the lower trunk. This technique was initially given by Winich. Now coming to the ultrasound guided interscalene block. See the this is root and trunk as because in interscalene block we block the root and trunk, proximal trunk or root. In supraclavicular block we block the distal trunk or division. In infraclavicular block we block the cord, and in axillary block we block the terminal branch. So it is interscalene block. So here we block the root and trunk, either root or proximal trunk of the brachial plexus. This is SAM stand for scalenus anterior muscles, SMM scalenus medius muscle, SCM sternocleidomastoid. This red color dot showing color Doppler using vertebral artery, and this arrow showing direction of block needle, and this is your USG probe. So at the level of cricoid, either you going from trachea to the lateral, from starting from the probe start from the trachea to going through the lateral at the cricoid. This is the here it is showing anterior scalene muscle. It is anterior medial scalene muscle. From this is lateral, this is medial, and as the needle is going from lateral to medial and in plane approach, this at interscalene block, this is traffic light sign is seen. But in case of supraclavicular, where honeycomb appearance is seen, this is traffic light sign means when you this is three trunk is seen, and generally we give the drug first at the lower trunk, then middle, then upper, because if we give drug at the above trunk, then the lower trunk and middle trunk goes out more deep, and you have to push the needle more deeper. That is harmful for the patient. These are the side effects of interscalene block, but these side effects are mainly occur when we use landmark technique or PNS guided technique. But in USG guided technique, these are very rare. Such as the in near scalene groove, there is phrenic nerve is also there, and when phrenic nerve block is occur, there is may cause dyspnea, even respiratory failure, depending on the severity of lung disease. When recurrent laryngeal nerve is blocked, there is hoarseness of voice. When stellate ganglion will block, there is Werner syndrome, and maybe invariant epidural or intrathecal puncture may occur. Vertebral artery injection may occur because vertebral artery are nearby them also. Even half to 1 ml drug gone to the vertebral artery may cause seizure. Now coming to the supraclavicular brachial plexus block. The only just go to the here first we know the location of the supraclavicular block, brachial plexus block. This is the midpoint, just so the midpoint of the clavicle. Nearby that showing seen the pulsation of subclavian artery, just lateral, superolateral to the subclavian artery, there is brachial plexus for subclavian technique. Clinical application, it is indicated for operation on the elbow, forearm, and mid-arm, below mid-arm. Blockage occur at the level of distal trunk and proximal division. The plexus is compact at this point, and a small volume of solution produced rapid onset of reliable block. Now coming to the ultrasound guided supraclavicular block. This is the probe placed just above the clavicle and parallel to the clavicle, and this as the direction of the needle is parallel to the direction of probe, so it is in plane technique. Here we see this is a subclavian artery, and this is a lateral, this is a medial, this is pleura, this is first rib. Going from lateral to the medial, this honeycomb appearance just superior lateral to the subclavian artery. This is honeycomb appearance is the brachial plexus, and we give the drug here around when we use ultrasound guided, just 10 to 15 ml is just enough. But when we use blind technique or landmark technique, about 30 ml to 50 ml, 25 to 30 ml in adult patient. Complication, when we use blind technique, high chance of pneumothorax and Horner syndrome when stellate ganglion is blocked, phrenic nerve block, and neuropathy when we directly hit the nerve may cause neuropathy. Now coming to the infraclavicular block. In the infraclavicular area, the trunk divided into anterior and posterior division each, and then reformed to lateral, medial, and posterior cord. The infraclavicular approach blocks the brachial plexus at the level of cord. Clinical application provides homogeneous anesthesia to the brachial plexus and can be used for procedure involving arm, elbow, forearm, and hand. In landmark or PNS guided technique, there are mainly two approaches used: classic approach and another one is Kuroket technique. Classic approach, patient lies supine with head turned slightly towards the contralateral side. Operative limb is abducted to 90 degree and axillary pulse is identified. Midpoint of the clavicle is identified and a needle is inserted 2 centimeter caudal to this point at an angle 45 degree towards the axillary articulation. This is diagram showing this is the midpoint of the clavicle and injection site is this, infraclavicular injection site is this, and the direction of needle is your at the axillary artery pulsation. This is the classic technique, and another technique is Kuroket technique. With our patient arm in any position, the Kuroket process is identified and marked. 2 centimeter medial and 2 centimeter caudal from the Kuroket process. The needle is injected perpendicular to the skin till motor response is achieved with the nerve stimulator. This is the Kuroket technique. Here is the Kuroket process of the scapula, just 2 centimeter medial and just and caudal, the insertion site of the needle go perpendicular to the skin, and when paresthesia or PNS guided technique is used, the drug is given here. Now coming to the ultrasound guided infraclavicular block. Ultrasound guided block, this is the technique also known as para-Kuroket technique or parasagittal technique. Now a newer technique of infraclavicular block is postoclavicular technique. First coming to the older technique, that is para-Kuroket or parasagittal technique. Here it is the lateral cord. Here it is the lateral cord. It is the posterior cord. It is the medial cord. This is axillary vein. This is the axillary artery. Red color is axillary artery and blue color is axillary vein. This is the your USG probe. Placed just in 2 centimeter lateral and medial to caudal to the just medial to the Kuroket process. Probe is probe cephalate to caudate direction, and your needle direction is from cephalate to caudate. First, just cephalate and supplicate to the axillary artery. Your lateral cord is there, and just dip to the artery, dip to the artery posterior cord, and between axillary artery and vein your medial cord is there. But, so you when we give the drug, you also give drug, some drug here, some drug here, and some drug here. So and also when you use USG probe, this lateral cord is very easily seen, and but posterior cord and medial difficult to see. And one thing I have also told that when we use a block at interscalene block and supraclavicular brachial plexus block, the nerve is hypoechogenic. Hypoechogenic matlab that is black in color, but beyond infraclavicular, axillary, and distal extremities, nerve bundle is hyperechogenic. White in color. This is because as distally there is more fascia, and that fascia causes white in color. So in infraclavicular approach block, the cord are seen white. This is hyper, but priorly here this is hypogenic, black dot honeycomb appearance also seen in. This is hypogenic. Okay. hypoacoustic, sorry. Now coming to the second recently developed infraclavicular block named as costoclavicular brachial plexus block. It is given by Karmakar et al. Have recently described a alternative approach to the sagittal or paracoracoid approach of infraclavicular block. Ultrasound transducer is placed parallel and inferior to the clavicle, and the block needle is inserted in plane from lateral to medial direction into the costoclavicular area, and the anteriorly clavicular head of pectoralis major and subclavius muscle, and posteriorly posterior surface of clavicle and second rib. The compact organization of plexus at this level, clustered lateral to the artery and more superficial than in sagittal approach, allow the blockade with less volume and single needle. This is the two diagrams. This is paracoracoid or parasagittal technique, and this is lower diagram is for costoclavicular technique. Difference is here lateral it is axillary artery and lateral cord is here, posterior cord is here, medial cord is here. Okay? But in costoclavicular approach, just proximal to the paracoracoid approach, here lateral cord, medial cord, and posterior cord all are at the same point. So single injection is just enough. So less drug is required, and this cause less chance of systemic toxicity. But here more volume of required because lateral cord is somewhere else, posterior cord is somewhere else, and medial cord is somewhere else, and also problem of vision in ultrasound guided technique. But here when we go from just probe is placed inferior to the clavicle, and your direction of probe is just cephalad to view the just inferior to the clavicle structure. When we go from the lateral to medial side, we first go in pectoralis major, minor, then subclavian superiorly, then these are the nerve, and then below that this is serratus anterior and rib, and this is axillary artery medial to that axillary vein. Complications when we use blind technique or patient pneumothorax, hemothorax, calothorax. But and one of the contraindication to use the inferior infraclavicular approach is when a patient with vascular catheter in subclavian region or patient with oscillator pacemaker. We have to avoid the infraclavicular approach. Now coming to the axillary brachial plexus block. It was first described by Halstead in 1884. Advantage of axillary block is single landmark, that is axillary artery, and no possibility of pneumothorax, stellate ganglion block, recurrent laryngeal block, pharyngeal nerve block. But the subclavian artery continues as axillary artery in the axilla beneath the clavicle. At the lateral border of pectoralis minor, the cord from large terminal branches. The facial sheath is multi-compartmental, and facial septa may result in incomplete spread of LA with plexus, leading to patchy anesthesia in many patients. Indication: the approach tends to produce most intense block in distribution of C7 to T1, means lower trunk, lower root value, but is usually indicated for procedure on the shoulder and upper arm, such as C5 to C6. So one of the disadvantages is spare musculocutaneous nerve. When we give axillary nerve block, we have to give musculocutaneous nerve apart from that in between coracobrachialis muscles and brachialis muscles. Technique of axillary block is performed by one of the several techniques that usually axillary arterial pulse as landmark. Patient positioning: patient is placed supine with arm abducted, the elbow flexed at 90 degrees and externally rotated at the shoulder, leaving the arm lying beside the patient's head. This is the position when we give axillary plexus block. One of the blind technique is transarterial. Just insert the needle beyond, in the artery, and blood is aspirated, go beyond, either beyond the artery or just proximal to artery, or given both sides, anteriorly, posteriorly, around 40 ml of drug is given. Now coming to the ultrasound guided axillary nerve block. This is the musculocutaneous nerve, as I have described. That musculocutaneous nerve is already proximally branched. So when we give axillary block, musculocutaneous nerve is spared. It is between coracobrachialis muscles and bicep brachii. It is here. It is radial nerve, axillary artery. It is axillary nerve, axillary vein. It is a radial nerve. It is median nerve. It is musculocutaneous nerve. It is ulnar nerve. When we this is lateral, this is medial. This is the position of the probe at the axilla, and this is arrow when we give insertion of the needle, direction of the insertion of the needle. When we go from lateral, this is lateral, this is medial. When we go from lateral to medial, first median nerve is comes just above the axillary artery, and ulnar nerve is between the axillary artery and axillary vein, and the radial nerve is deep to the axillary artery. So loads of volume is required because the three branches are at different places. Now coming to the digital individual nerve block. First coming to the and different side, we can block that individual already described that we can block radial nerve, ulnar nerve, and musculocutaneous nerve and median nerve, and also at different side. One side is at the elbow, just above the elbow. Another side is at the mid forearm, and third side is wrist block. So first coming to the just at the elbow side at the medial side, there is at the it is lateral side, as because it is lateral because its thumb is this side lateral, just above the lateral condyle of the humerus. Probe is followed transversely, and direction needle is going from downward to upward, out of plane approach, and radial nerve is between brachialis muscles and brachioradialis. This is superficially, and this is deep, and this is hyperechogenic because white. And coming to the median nerve as this is the thumb, this is lateral side, this is medial side. So median nerve is placed medially. So just a mnemonic can be remembered: MBBR, median nerve, brachial artery, bicep tendon, brachial artery, then radial nerve. This is the medial to lateral. These are the structure at the elbow. When we give press the probe at the just above the elbow transversely, and needle direction is from distal to proximal. This is the brachial artery, just lateral, just medial to the brachial artery. This is an honeycomb appearance and hyperechogenic structure, that is median nerve. We have to give the drug here. Now coming to the median and ulnar nerve in mid forearm. Here it is medial direction and it is lateral. It is ulnar artery, just lateral to just medial to the ulnar artery. This is ulnar nerve, hypoechogenic, and at the medial direction, at lateral direction, this is the median nerve at the forearm, mid forearm. Now coming to the wrist block. Wrist
Hello,
F3.
hello.
Dr.
Excuse
Bari.
me.
Yes,
Dr.
yes,
Bari.
yes.
Dr. Bari, you can
Yes, I
sum up
can
now.
hear.
I think you can sum up.
Okay, okay. Just 2 to 3 slide more. Can I describe or stop
No,
here?
it's fine. You are just actually just taking pictures from textbook and putting it. There's no personal touch to it. I think it's not necessary. Nobody
Okay,
does
okay, okay. Sure, sir,
ultrasound.
sure.
Nobody does ultrasound at the wrist level for.
Okay, okay, okay. Sure, sir. Just stopping the sharing.
Yeah, Dr. Shiv, you can sum up the thing.
Yeah, Nasrul, I think you're a senior resident. I think you should have taken some help from at least some consultant before you presented, because people are, spending their precious time on a weekend. Yes, this is Sunday, right? Listening to you, I think your preparation could have been better. You have just taken snapshots from the textbook and put it there, and you're reading the text. That's not something we expect.
Okay.
Yeah, I think I'm more than happy to mentor anyone. If you actually have in the future, you want to improve your slides, you want to learn how to do presentation, you can. That's not the way. I think you're still a senior resident, you're still in a learning phase, so you can
Yes,
obviously actually pick up these skills. Because it was all read from the book, I do not know what to actually say much. These are blocks which are commonly used as people start using ultrasound mainly for upper limb.
Yes.
And then they move because it's a skill which students or the trainees pick up very easily. So even though the brachial plexus, still people likely don't get it absolutely right, but I think it's a steep learning curve, and they get the skills very quickly. Do you regularly use ultrasound for blocks?
Yes, sir.
So you could have taken your own videos, isn't it? You could have actually got someone to show you. I think that would have been more interesting to see how you're doing. So, for example, it's very important to know how you position the patient, how you actually have the machine, where the probe is coming from. Well, all those things can be easily shown by just making small videos. Right. And that would make it very interesting. And plus, you have to just describe what are you doing. Yeah. So coming to the crux of it, so like interscaling blocks, I actually start teaching people to actually put the probe just above the clavicle first, because you can actually see artery.
Yes, sir.
And you know that the lateral to artery is your supraclavicular.
Yes, sir.
All you need to do is the probe is actually put around 45 degrees to the neck, as if it is looking into the lungs, and you see the brachial plexus, you see the supraclavicular area. Now, all then you need to do is actually straighten the probe so that it is perpendicular to the skin, and just glide it up till you actually see the interscaling groove. You can actually follow the whole procedure. The mistake which people actually make with interscaling is that they start scanning from much higher up. They don't actually see it. You don't have to. Better to actually start from the supraclavicular area. Okay, put it at 45 degrees, looking into the lungs, and then just straighten it and move up. Follow it, and you will actually see it. You get a beautiful images. And then supraclavicular is just starting where you started from. So you've done two areas already covered. So one video could have covered that. Infraclavicular is not as popular because the plexus become much deeper. And there is not much difference, actually, if you look at, if you can do supraclavicular, people say there is risk of pneumothorax. No, it is not. As long as you have good hand-eye skills, coordination, you actually continue to, you do not inject till you actually see the tip of the needle. Okay, do not move. Okay, just don't be blind. So you actually be careful. And then you will never actually ever do a pneumothorax. In none of our trainees till now actually have done any pneumothorax with supraclavicular. So if you can do supraclavicular, then you are actually a winner. And then axillary, yes, axillary actually is a good, but actually if you do axillary, the more you do, the more you realize how did we actually, went without actually injecting into the vessels. There's so many vessels there. Vein get compressed because, like I was talking, in parts you press the tissues and the vein get compressed. And there are actually so many veins actually in that area. When you actually start, you release the pressure and you'll see so many veins there. So it's not okay, you may not do pneumothorax, but you can easily actually do an intravascular injection in axillary blocks. But what is important to know, if somebody has to actually learn ultrasound for upper limb, I would actually teach them two things. One thing is supraclavicular block, and other is individual nerve blocks.
Yes.
That is to rescue. So if you actually miss out something, then you can rescue. Okay, that's all is it. The wrist block, nobody is doing this. Wrist block was done as a blind technique. Okay, you don't. If you are blocking nerves at the elbow, you can actually see some of the videos I have actually presented, and they're so easy to actually locate the individual nerves. Yeah. So upper limb is something I think as trainees, everybody should actually learn to do supraclavicular first. Okay, don't be afraid of pneumothorax. Just be careful. You don't actually just pass the needle suddenly. Master supraclavicular block and the individual nerves which are easily seen on ultrasound. Even if you actually have the worst kind of ultrasound, you will still see them. Okay. You just need a little bit of skills. Okay. One other thing which I actually wanted to mention in some of the places on the videos is that, videos, they are not actually paying attention to the basics. Okay. The depth, right? Depth is very, very important. So as you go deeper, if you are actually now, less deep, you're superficial, you see a lot more structure. As you go deeper, everything narrows down. So everything below this is a useless information. So you are actually losing all the advantage of actually using an ultrasound. So you are actually seeing, especially I think when it was Tushar was presenting like IV access, he had the depth, so much that is not required at all. It's so superficial. All that information was useless. Plus you're losing all the, like it's like your side vision is gone, so you are actually like having, so deeper, you go deep, but loses all sides. So as you become superficial, do actually reduce that. And then gain is again, you can actually, just with a single knob, you can do that. And a lot of them actually have auto gain button. You just, once you actually have the right depth, then you go for the auto gain. And normally most machines actually have slightly reduced gain. You can then increase the overall gain, and then you get a beautiful picture again. So there are very simple things to actually learn from these. There are other things than, what is the position of the patient? Okay, supraclavicular, if you're doing supraclavicular interscalene block, what I would suggest you to do is actually sit up the patient, 45 degrees.
Yes.
The hand will fall off. Okay, you will actually create a lot of space. Right. So that is there. Then again is interscaling, your pillow will come in the way. So how you adjust the pillow to one side, right? That all those things, how you actually going to actually, get the needle in play. You can get a good picture with a probe, but you also need to get the needle in. So creating a space is equally important. How you actually have the head position, how the pillow is there. Creating that space is equally important for supraclavicular and interscalene block. So these are just simple stuff. Anybody can actually do it. How you push. Ergonomics is very important, where you are going to keep the machine, where you're going to stand. You make yourself comfortable. And one of the other things is I actually see when people are doing blocks is that they try to hold the probe. The way you hold the probe, it's not mandir ki ghanti nahi hai ye. You're not actually ringing a bell. If your hand is actually in the air, you will never get a stability. You need to actually hold the probe properly, and you actually have your palm resting on the patient so that you can do very fine movements. Here, the movements are actually looking at like 1 degrees, 2 degrees, that slight tilt. It is not, moving like, like the pendulum. You actually have to make very fine movements to actually see the needle. And that requires you have to have stability of your hand, how you're actually putting the hand and holding the probe and doing that fine little movement. And then you'll see, oh, everything is visible. You also need to have three-dimensional actually imagination. Your needle is actually going this way, your probe is there, you're not going to see the whole needle. You have to see, oh, which direction my needle is going and how I need to actually turn the probe. And it's always one movement at a time. Either you move the probe or you move the needle. Don't do two things at the same time. So if you actually have the probe stable, then you can actually then guide your needle, say, oh, I need to actually go straight, okay, or I need to go get the needle medially or laterally, whatever. So these things will come. Like nobody has become an expert in a day, right? We have actually graduated doing blocks, hundreds and thousands of blocks, and then you reach a level where you can actually then guide others. So at your level, okay, yes, I wasn't pleased. I was actually, thinking, ye kya kar raha hai ye ladka? He's just reading and putting that, if you had actually just done your, blog apna hi, you would have made your own videos. It would have made a lot more interesting. That theory anybody can read. Everybody knows how brachial plexus form. You first year anatomy में पढ़ाते हैं. BD चौरसिया में है. Gray में भी नहीं जाना. You can go to BD चौरसिया and you get a good actually description of brachial plexus. But that is not the idea. Idea ये है कि how do you actually start using ultrasound for blocks and how effectively use, where you use it, and then some of the finer tips you'll always get from seniors or when you listen to them.
Thank you, sir.
Thank you.
Yes,
Yeah.
Dr.
Thank you
Shiv.
very much.
your
Yes.
suggestions are well taken. I think you have hit the core. And Dr. Sharad, now it's your role to see to it that, of course, we have to discuss few advanced things. We have to also see to it that basics are taken care. But what Dr. Shiv has very categorically and very polite manner he has mentioned, that whosoever is presenting should have some mentorship from the
Yeah.
senior, because everybody's time is very precious, and everywhere we try to learn. Sometimes we also learn from the other's mistake. There's no harm, but at least some quality control, I think, should be in the place what he wanted to say. And so next time, Dr. Shiv, I think we will take care of that. Whatever you have suggested, you have elaborated, I think, all the aspect of good presentation, good work, don'ts and do's, everything you have mentioned. And Dr. Sharad, now it's over to you.
Yeah, like I said, I'm actually happy to mentor anyone who wants to actually even show me their video, the presentations or thing. I'm more than happy to actually help them out. It's they're most welcome.
Yeah, Dr. Shiv, you are doing a lot. I think it is for those who are not knowing you, that how much you are doing and contributing to the teaching. And you always open to mentor anyone from any level. I have seen you practically also. So you are most welcome, and I think it will go a long way for the Jharkhand and Bihar.
Thank you.
Not only that, see, we should have a webinar etiquette. Actually, we made a webinar in Kerala from Kasaragod, webinar etiquette, because there are people who say that how should be your slide, how many letters in the slide, how it should be, how you should present your slide, how you have to behave yourself. See, we have seen that people in the webinar with the relaxation stage, whether you have to, when you have to switch on your mobile, when you have to, there are things that if you have, you can log into that and Kerala webinars, and one webinar we made for 1.5 hours with faculty. See, that's also very important. The people should know that how to prepare slide, because experts have one slide should have, if you talk Balabhaskar, he will take a class on. Each should have this many slides. There should only too many this thing, the color combination. That is all attractive. All many things may be very attractive, but it is not pleasing to us. We should have that, because these are few things other than learning our subject. What, how we to keep these things also important. Maybe one webinar we can have that for some time, and people will learn that. Even juniors, even seniors, they should know that. See, sometimes there's too many things. You can't have anything. Yes, you should have this one. That is also required.
I have actually made a video of that in 2014. It's there on my YouTube. It's about effective presentation, and I actually mention all those points. They're very easy to actually follow. I think in the end, you will realize as you get senior, simplicity is the best thing. So all those, when you are actually, learning, you want the slides flying, words flying from here, disappearing, appearing, and then you want jazzy background, and then suddenly you realize, no, that doesn't matter. What matters is your content. So just simple white background, blacks, letters, or it can be, some people like black background, white letters. This is all that you need. And in the end, they're going to listen to you. Yeah, that's more important. Your content is important. What you actually are saying, that is more important. How you deliver it is more important. I think it's very late in India, I think, isn't it?
Thank you very much, sir. Thank you very much, Dr. Shiv Kumar sir and Dr. Ashok Jadan sir, for moderating this session so well, and lots of learning for everyone. Especially, we always invite our postgraduate students. Please come, join, learn how to present. That is very basic things. We always encourage the motto of this CME, especially to young doctors, the postgraduate students, young fresh passed out doctors. Please come forward. Come out of your hesitation. We want that you should present at the state level, city level, then you can reach the national level. Always want कि शरद सर मुझे नेशनल में पेपर दिलाई. हम बोले यार पहले स्टेटी लेवल पे प्रेजेंट करो, 10 बार करो, 12 बार करो, then you learn from your mistakes. That's why we have so many stalwarts. You are there, Jadan sir is there, Dr. Venkat Giri, Nivita Pani, I can see Dr. Nishant is there, Dinesh sir is there. So many stalwarts who can help. I myself can help if they want any help. So this is the things we presented to our postgraduates, but somehow there is some disconnect. I still always say our postgraduates are not coming forward. In fact, this aim was to just go with them, come, listen to the speakers, how they speak, what they are speaking, how to make the slides, how to present. See, we all have hesitations when we are presenting and with so many big faces, but that is the way of learning. Failure is the way of success. 10 बार करोगे गलती, 11वां बार start हो जाएगा ठीक से. But you have to listen carefully what Dr. CU, Dr. Jadar is saying. So they have come, they have reached this place only because of their, continuous effort. एक दिन में सर ने कहा ना, कोई आदमी आगे नहीं बढ़ता है. धीरे धीरे gradual progression is the way of life. So thank you very much, sir. Today we have 2-3 very eminent guests with us also, Dr. Nivedita Pani, Dr. Sukhdev Nayak. Welcome, sir. Dr. Sukhdev Nayak, sir. Very happy to have you, sir.
Namaste,
Dr.
namaste.
Nivedita
Good
Pani,
evening.
thank you very much for joining. Always pleasure to have guests with us because this is a sticky branch CME of Bihar, Jharkhand. But when you have guests and senior people like us who gives input to our postgraduates and the freshly passed anesthetists, we feel happy to connect with them. So just 1 or 2 sentences from Dr. Nayak and Dr. Nivedita Pani, then we will move for the valedictory by Dr. Neelam Sinha. Yes, Dr. Sukhdev Nayak, sir.
No, it is always good. Whenever you, I must congratulate the Bihar Jharkhand because they are doing regular. Actually, it's a learning process for me also. But I don't see many postgraduates as just Saroj was telling. I think there are only about 30, 35, 38 people. I think it should be widely publicized because there's no limit to learning. And I always congratulate Sarad and his team, regular CMEs, and it's good. The younger people and the elders all should join. Thank you very much.
Thank you, sir. We are trying our level best to involve all the postgraduates. My focus is always the post-PG students. But somehow I think we need some inputs how to get them. I don't know. I am missing something. I have to ask to our seniors. So how to bring them on the platform, because this is the free platform we are giving to the, they can talk to Dr. CU directly. This is the benefit of the digital media. This is the COVID positive things I can always see. I am talking to Dr. CU, such a famous teacher all over the globe, and you are not asking a question. That's not good, sir. You should ask, come out of your hesitation. That is my motto. So, Dr. Nivedita Pani, she is very close to Bihar and Jharkhand, always there with us. Would you like to say something? Dr. Nivedita Pani? Okay, I think I am. Hello?
She's here.
Am I audible?
Yes, madam, you are.
Thank you, Sarath, for inviting me. And it is really from the evening, I was really enjoying, because tomorrow election is there, but listening this, I was really enjoying and very comfortably also listening to all the talks. And SIRS is a very wonderful program, and it is very helpful for the postgraduates actually. Really, it is very helpful. And Sarath, we can do one thing, as we are the neighboring states also there. So whenever you can make any program also, we can tell my postgraduates to join also. So there is no problem. Just send me a link. If any good, anything related to this thing, we can join. So I am ready for that. So that it will be a very nice joint program. It can be done also. And whatever we will do any program also, we will ask you all to also join. Thank you. And march ahead. Do well. And I need all good wishes from all of you for coming program. Thank you.
Madam,
Thank you very much.
Madam.
Thank you very much. I will call. Yes, Dr. Manoj.
Nivedita Pani, madam, warm welcome to the IC Bihar Jharkhand CME program, and my best wishes from for today. IC online election. So as a zonal GC member, my best wishes to you for president-elect.
Thank you.
Madam.
Thank you, Manoj. Thank you.
Thank you.
Thank you, Dr. Manoj. Thank you very much. Thank you, Dr. Nivedita. Now I invite our treasurer, Dr. Neelam Sinha, madam, to start the proceeding of the valedictory, to give away the certificates to all the speakers And for that, I will request our moderators, Dr. Shiv Kumar and Dr. Jardin, to give away the certificates to all the speakers. Dr. Neelam, please start.
How do you do that?
Dr. Neelam.
Yes, sir.
I think, please give this honors to Dr. Shiv Kumar.
I don't know how you're doing it. No, Dr. Ashok, you're the senior one. You
No.
please,
You take the
आप
lead.
senior हो ही
अरे ठीक है यार.
ठीक है
Yeah, Dr. Neelam.
Yeah. Thank you, sir. Good evening, Shiv sir, Jardin sir, all the dignitaries and the moderators. We are coming to the valedictory session. A very exhaustive lecture and speech by our speakers, the honorable speakers and our moderators. We are big fan of Shiv sir and Ashok Jardin sir. Always we learn whatever there is on the social media platform or in the hospital. We are always there. So I would request Dr. Shiv sir to present the certificate of participation to our esteemed speakers, Dr. Gautam Piplai.
So the
Dr. Neelam, you have to tell how to give it.
I don't know.
Sir will just tell. It is online. It is visible. It is visible. Sir has to just tell them, and then we will send them in their WhatsApp or mail. Yeah.
Okay. You just.
I think. Thank you, Professor Gautam, for the lecture and taking your time for presenting this lecture. And it's a great pleasure to award you certificate of participation on behalf of Bihar Jharkhand Society of Anesthesiologists. Thank you very much.
Thank you, sir. Next speaker is Dr. Tushar. Just a minute.
Tushar, are you there? If you are there, please say hi, hello to everyone and say thank you to
Hello, sir. I'm here only.
Very nice.
Yes, sir.
Just a minute, Sharad. It's not moving. I don't know why. Dr. Tushar.
Yes, thank you, ma'am. Thank you very much.
Dr. Ashok, आप दे दो भाई.
चलो ठीक है. Yeah, Dr. Tushar, you presented well, and it
Thank
was
you,
really a very useful topic to all of us. And
Thank you, sir.
I'm very happy to give you this certificate of participation. And thank you for your participation and making us enlightened with the knowledge. Thank you.
Thank you for the blessing. Thank you. Thank you.
Well done, Tushar. Very well presented.
Thank you, sir. Thank you for the blessings.
Just a minute. There's something wrong with the sharing.
Network is slow, I think, ma'am.
नेटवर्क का कुछ इशू हो रहा है. मैं देख रही हूँ.
Move on. We will send to the WhatsApp and the email ID. Just take the name and we can, because we are already running late.
Yeah. Just a minute.
Okay, ma'am. Okay.
It's not moving. I don't know why. I'll share it again. पापा
Dr. Neelam, is any issue in the sharing that you can send it? We can name
yes, I'll send, but I'm trying to share it. Dr. Vimohan Kumar.
Yeah.
Dr. Vimohan, please collect your certificate from Dr. Shiv Kumar.
Yeah, Dr. Shiv.
It's a great pleasure to actually award this certificate of participation to Vimohan. I've known him for a very long time, and he has actually done a tremendous work in intensive care and started using ultrasound pretty early in the intensive care when nobody else was using it. So It's a pleasure to present the certificate of participation to V. Mohan. Thank you very much, V. Mohan, for your lecture. And it was very good. It was excellent.
Thank you, sir.
Dr. V. Mohan was our faculty at the recently held East Zone and State Conference, and he was very well appreciated by all the participants. Very learned man, and he is a prominent. He is going to be the face in ultrasound in near future. Excellent presentation, V. Mohan.
Dr. Ashok sir, present the certificate to Dr. Nasir.
We are happy to give this participation certificate to Mohammad Nasrul Bari.
Thank you, sir.
But you prepared well. But as Dr. Shiv already highlighted the issues, I think you should have presented with your own work and we would have enjoyed. Anyway, it is always next time for the doing better. So nothing feel bad about it. And we all actually in the learning phase, every day we learn. So we are happy to give you this certificate of participation. Thank you, Dr. Mohammad Nasrul, for participation. Thank you.
Thank you, sir. Thank you. Thank you, Jadon sir. Now I'll request Dr. D.K. Singh, President, Bihar Jharkhand Society of Anesthesiology. Dr. D.K. Singh, sir.
हाँ मैडम बोलिए.
I'll request you to present the certificate of appreciation to our moderators, Dr. Shiv, sir.
Okay. Dr. Shiv, sir, this is my great pleasure to present you the certificate from the Bihar Jharkhand Society of Anesthesiologists. You are a great teacher, sir. And we will also expect you in the near future to come with us and bless us. Thank you, sir. And please accept the certificate, sir.
Thank you. Thank you very much, Dr. Dinesh. Thank you very much. It's a pleasure.
Okay, sir.
And to Dr. Ashok, sir.
Dr. Ashok Jadam, my dear colleague, I feel honored to present you the certificate of participation and appreciation from the Bihar Jharkhand Society of Anesthesiologists. And you are a great teacher. You are a great teacher, and we still want your guidance to our PG and us too. Thank you, sir.
Thank you, sir. Thank you very much. But one thing I would like to tell Dr. Shiv that next time, if like you participate in our Bihar Jharkhand, you will see the better presentation.
It will, absolutely.
Sure.
I think so. I think every
we can promise
time we will do some scrutiny.
Yeah. I think every
we can
every opportunity we could learn.
Fantastic.
Yeah, we learn new things. Yeah.
Thank you, D.K. Singh, sir. Thank you so much. Now over to you, Sharad.
Thank you, madam. Thank you, Vinita, Neela, madam. Thank you very much. Now, I invite our chief guest of the day, Dr. Venkat Giri, sir, because he is with us since 7 p.m. and it is very important to hear his view also about these presentation, because he is going to the president also and he is very close to all Bihar and Jharkhand members, and he always give positive inputs. So what to do, how to improve, what you are lacking, that is also important to know. What we are missing, why people are not getting connected with us, especially our postgraduates, because our aim, as I told, is to add all the postgraduates of Bihar and Jharkhand, so they get prepared for the higher level. So I think we all want to hear Dr. Venkat Giri view. Because, sir.
Thank you, Sharad. Good that it was a nice program with ultrasound and all. What we observed, because we were conducting weekly CME in webinar from Kerala. What I was observing myself and secretary, because when the speaker is a very well-known speaker like that, there were a lot of participants. Even in Gurudat from Mysore, if he is there, that day we will have 300, 400 participants. If the other like that, if there are few speakers like from Jipmar, what's name? I don't get that. If he comes like that, there are few people. If Ram Kumar comes,
Ravi Shankar.
There are a lot of people coming in that way. Then there are second level. If there are, they think that our PGs think that okay, this we can hear anytime, and that is what these PGs feel. I think Definitely. But with Shivkumar Singh coming, I do not know why the people have come less. Because maybe that is from south part. See, if it is in the north part, there may be some known speakers and exam. Then like examiners, because we were thinking the exam, yes, they know that he is asking, they want to know what is his questions and all. We made it a webinar for that. Even DNB exam going before that, we conducted for 2 days continuous. That's a good attendance. But there also we were selecting that if the exams are there or if the speaker is just anyway, always that when Gurudat from Mysore there is always jam packed. It was always full 300 that capacity within that at the time start it is 300. Then people go to the live in the YouTube. This is what. And if there is a YouTube also, people will think, okay, I will see it afterwards in the tube. There are a lot of hits. If I see the statistics of the YouTube of the Kerala, when it's Gurdats and all, repeatedly it is coming. That is one thing. And think the topic which is of importance for them and all. If they hear some topics repeatedly by somebody and others, people go for that. That are the two reasons why. So what we did was at least one speaker, he is good. But here, I do not know why with Dr. Kumar Singh, who is
I wasn't presenting. I was not presenting. I was listening.
That may be one reason. Yes. That may be one reason.
I was only listening to them.
Yes, that's why I'm telling Sharath, when you're making that one speaker, you make that that is a known speaker from all that is examiner, or so that always this our PGs come and log into that and do that. This is what I observed. But what happens is the people say that you are promoting only that seniors come. People say that you are not promoting speakers from our state. You are making from. See, even in my own state, it said that when Gurudat and others, I selected all national speakers for all that, so that the people should be exposed to this. Because see, now people have an opportunity to hear speakers from outside. Others, when other time, maybe 1.5 years, they were hearing only their teachers teaching. Classroom teaching. Now they are hearing teachers from all over India. They are blessed to have these classes. See, we were you keep on case presentations, not only theory lectures. We did case presentations. Okay, thyroid case. One PG will present and his teacher will be the moderator for that, and another one external examiners. It's like a true examiner. 1.5 hours you take a thyroid case or a liver case, and one internal, one external examiner. Lot of people will come. That will be good also, because that discusses both theory and the practical aspect. Even your brachial block, you see that a 70-year-old man comes with the fracture with his COPD and CAD, what then he can discuss about everything, including a block and all, so that more people will attend, and it is both practical and theory. This is what we observed, the good participation. Now, not that this is not good. We should have. What we made was there was one theory class, there was a clinical class, because theory, okay, we even thought of making drugs, because people wanted to know that. Because Balabhaskar, he explains very thoroughly about the drugs. He told, okay, local anesthesia. Like we need that when the PGs for theory, they need all this. Say one class, you can make one theory class, one case presentation. Yes, definitely they will attend and all. We can have. This is what my observation attending so many webinars and all. We are seeing that 1 year, maybe around 50 webinars and 4 full-day classes for the 4 times for this pre-examination, both for MD of Kerala and for the DNB we conducted. This is what we observed. Then really people will come more for theory, then OSCE, all we have to teach them. They will come. Need not be Bihar only. You can make whole the East zone. You can make and all. Involve all the people. Then you know who are the exams coming there. Take them. What exam? What question they ask? Our exam PGs also know that external exam. What are his favorite questions? How we have to face the exam. These are also important things. Maybe you make it 2 months before the exam. They will come and they will also make the exam going PG to present the papers. Because your state PG is presented in our state webinar. We told, okay, anybody come is welcome. This is what is happening. So I think Shipma, you can also say that is it right or any other additions? Because this is what
very absolutely valid point. I think students will come where they find there is some interest in there, something which is useful for their exams, practical purposes. I think one of the problems with postgraduates is they do not have as much exposure to ultrasound. So they think that, okay, we can listen to it, but if you're not able to go back and touch an ultrasound machine, what's the point? So I think some topics are going to be like that. But they also have to understand that they still ask questions in the exams. Even if you do not have ultrasound machine, they still likely ask questions. So they still be useful. You will always pick up something or the other, something new. But more practical, I think, topics will obviously fetch more. Case-based discussions always actually are very interesting. I think the way V. Mohan presented the cases, I think he did very well in that. He actually took cases. Yeah, he was rushing through the things, but I think the way he actually did it, that was excellent.
Yes, sir. Well said, sir. Thank you, Dr. Venkatgiri, sir, and Dr. Siv, sir, for spending your valuable time with us and all the guests, Dr. Sukhdev, Dr. Nivedita, and all our members and moderator, Dr. Jardan, Dr. Manoj, our GC member. He is always with us and the bridging force between the national and the state. Thank you, Dr. Manoj, for getting connected with, and Dr. Neelam and Dr. Rakesh. You are from the Katihar branch. I want to just your opinion also, Dr. Rakesh. Can you hear me? I think he is muted, Dr. Rakesh. If not, then we will start. I will ask Dr. Neelam to please give the vote of thanks. And because it's already 10 p.m. India and must be around 6:30 in the UK. So it's already late. So I request Dr. Neelam to give the vote of thanks. Please unmute yourself. Or anyone wants to say anything, any suggestion, please come forward, then we will take. If yes.
Winter time started from today in UK.
Hello.
So it is now plus 5.5 hours now difference.
We started at 7. It's 10 2 to 3 and 3 hours, sir.
Dr. Sukhdev wants to speak.
More hours, sir.
Sharon, Dr. Sukhdev wants to
So I request Dr. Neelam madam to give away the vote of thanks.
Sukhdev sir, you want to say something?
Just one. We at AIMS Bhubaneswar, we, because of the poor attendance, we have done twice in the evening rounds, evening topics, twice in a week. So that all the postgraduates will join. If you can make it mandatory, so there are so many HODs in this group. If they can say that this evening round of evening session is, they can make it a part of their academics, then probably the HODs say they can, because in our institute, AIMS Bhubaneswar, we have twice in a week evening 1 hour sessions, and they come, and because the teachers are there, they come. If the teachers can say that the students must join, and I think they will follow, at least the exam going. That is one point I think can be implemented, because there are so many colleges in Bihar, Jharkhand.
Thank you, sir. Good suggestion. We will try to implement that. So now I request our Neelam madam. She is the treasurer of the BJSA. And madam, please go ahead.
Thank you, Sharat. On behalf of the organizing team of Bihar Jharkhand Society of Anesthesiology, it's my privilege to propose vote of thanks. First and foremost, I would like to express my gratitude to all the esteemed speakers of today's webinar, Dr. Gautam Piplai, Dr. Tushar Kumar, Dr. Vimohan Kumar, Dr. Muhammad Nasrul Bari, for their excellent presentation and contribution to make this monthly CMA a great success. I extend my heartfelt thanks to our honorable moderator, Dr. Shiv Kumar Singh, to take out time from his busy schedule to grace this event. Thank you, sir, for always inspiring and encouraging us with your expertise, your teaching, and creating a task family for knowledge sharing. Thank you, sir. My special and sincere thanks to Dr. Ashok Jardan, sir, my mentor always, for providing immense support to make this CME successful with his expert opinion on ultrasound guided tips and tricks. Thank you, sir, for always encouraging us with your knowledge sharing. Thank you, sir. I would like to extend my heartfelt thanks to our dignitaries present today, Dr. Venkatgiri, sir, President-elect ISA National, Dr. Manoj Kumar, GC member ISA National, Dr. BK Prasad, sir, immediate past President BJSA, Dr. DK Singh, President Bihar Jharkhand, Dr. Motilal Das, he was present earlier. He is the President-elect for Bihar Jharkhand. Dr. Dev Sanjay Nag, Chairman, Scientific Committee, Dr. Nishant, Scientific Coordinator, Dr. Sharad, our Dynamic Secretary, always after us to do the programs. All the team members for leading and inspiring us in working towards the goal of creating this monthly CME. We are thankful to the entire team for their huge support. My special and sincere thanks to our guests, Dr. Nivedita Pani ma'am, Dr. Jami Sridhar, who was present from Canada, Dr. Sukhdev Nayak for sparing their valuable time to grace this event. Last but not the least, my sincere thanks to Mr. Anand from IT Solution, without whose support this event would not have been successful. Once again, thank you, all of you, and wishing all of you a very happy and prosperous Diwali.
And thanks
Happy Diwali to everyone. Happy Diwali to
thanks
everyone.
to all the members of the BJSA. And thanks to all the members of the BJSA. And
Thanks to
very much for sparing your valuable time on this Sunday evening. Even after India match, although India is playing very bad, my son came and told me, sir, India ki to lag gayi aaj. Never mind, we got the opportunity to listen the stalwart Dr. Siu, Dr. Jordan. We learned so many things, and that is the new beginning for the BJSA. We will definitely implement the suggestion given by all of you. We will try to improve.
Postgraduates have to come forward to attend this program.
This webinar. Happy Diwali, Dr. Shiv. Happy Diwali to others.
Happy Diwali to everyone.
Happy Diwali to everyone.
Happy Diwali to everyone. Happy Diwali, sir. President-elect, sir.
Bye.
Venkatgiri, sir.
Bye, sir. Thank you very much, sir. Thank you, everyone. Thank you.
Happy Diwali, everybody.
Good night. Happy Diwali. Good night.
Okay.